please stand up for the silent prayer. Thank you. Please be seated. Today we have one PG topic, some interesting or disgusting foreign bodies by Anju. Then we will have a short general body meeting. We are approaching 2 years and it's time to change. The next president and secretary are ready. As we have already announced a meeting this month, we will elect the office bearers in this meeting and installation will be in the next meeting. Then today's topic is that something like that hernia chat, the past, present and future of the surgical education. I welcome all the speakers for the speech. Now I request Dr. Dipin to read out the minutes of the previous meeting.
Good evening, everyone. This is probably the second last meeting. The previous meeting was held at Hotel Tripenda on 20th June. Around 90 people attended. We presented our last 2 years nutshell, and we have in between we have filed our income tax. We have submitted the audit report. So legally, I am free now. I have done all the legal formalities. After that, it was followed by a talk by Dr. Amar Prasad about TIRAT scoring. Active discussion happened after that, and the talk was by Dr. Mohammad Ismail about abdominal wall reconstruction. For a change, last time we had some music also. In the time there was a technical hitch. The meeting was urgent after National Anthem and dinner. As sir announced, we elected the coming president and secretary. Both are yet to reach, so we will announce after some time after GV consensus. So, can the minutes be passed? Okay, thank you. Now I welcome Dr. Anju. We were planned for a changing ceremony, but in short notice, I had only Anju to present that. Thank you, Anju. You can present that.
W small, exclamation, N small.
Good evening, everyone, respected faculties and my dear friends. Today I'll be presenting The Tale from the Unexpected, our intriguing encounter with foreign bodies, a case series from the Tertiary Care Center. We all know that the foreign body impaction and other complications are fascinating and challenging aspects of clinical medicine. Lack of proper history, spectrum of clinical features with which they present, their localization and management are indeed a hurdle for a surgeon. Here I am presenting a case series of 10 cases, that is interesting foreign body cases, with data collected over a time period of 2 years from the March of 2022 to March of 2024. We have about approximately 34 cases over these past 2 years, and 18 of them were managed conservatively, with 6 was managed endoscopically, and 10 cases had surgical management, and we are focusing on these 10 cases. If you look at the mode of the occurrence of these cases, 5 of them was accidental and 5 was intentional. In the intentional category, 2 were suicidal attempts, 1 was the assault, and 2 was belonging to other categories like sexual gratification. If you look at the location of the foreign body, 3 cases were upper GI cases, 5 cases were lower GI cases, and there were 2 other cases including the neck and the anterior abdominal wall. If you look at the severity, 4 foreign bodies caused perforation and 6 of them caused only impaction. When we look at the outcome, one of the cases out of the 10 had mortality. Let's go into the first case. We had a 15-year-old male who has a history of falling from height with a toothbrush in his mouth while brushing in the morning. And the patient came with a toothpaste sticking out of his oral cavity. As the patient was stable, we took a CCT and we were able to find that the toothbrush has pierced through the left part of the oropharynx into the left parapharyngeal space and reached the lateral aspect of the neck up to the subcutaneous plane. And fortunately, the foreign body had not injured any major structures or vessels in the neck. So our team took the patient to the OT. The team included of general surgeons, ENT and OMFS surgeons, and we put an incision through the neck, and we were able to take out the foreign body. The proximal part was in the subcutaneous plane of the neck, and we were able to take out the foreign body through this incision with the wound in the oral cavity being sutured by the OMFS surgeons later. The postoperative period was uneventful, and we were able to discharge the patient on postoperative day 5. Next is a case of a 23-year-old female who is a non-case of depressive disorder and postpartum psychosis. And the patient presented with complaints of chest pain and breathlessness to the emergency department. On examination, there was decreased air entry on the left side. Chest X-ray taken showed pneumothorax, left-sided pneumothorax with a long metallic foreign body with a hooked proximal end and a sharp distal end extending from the neck through the thorax into the abdomen. We did a left tube thoracostomy. A further CCT was taken which showed a linear hyperdense foreign body extending from the pyriform fossa into the mid-thoracic esophagus. It penetrated the esophagus and ended into the left hemithorax and then into the left hemidiaphragm and then into the abdominal cavity. There was a suspected bronchial injury as well as pneumoperitoneum. With a multidisciplinary team, including the general surgeons, cardiothoracic surgeons, ENT surgeons, and with an anesthesia team, we proceeded with the surgery. Initially, we did a bronchoscopy and bronchial injury was ruled out. Then, under video laryngoscopic guidance, the proximal end of the puppet stick was held with the grasping forceps and it was taken out with the cardiothoracic surgeons on the standby. After taking out the puppet stick, we did a fluoroscopic guided nasogastric tube insertion and then we did a laparoscopy and ruled out any bowel injury. The interesting thing was the foreign body that was taken out, that is a puppet stick, is a 38 centimeter long puppet stick, which is, according to the reviewed records, is the longest foreign body that is recorded till date. Then we have a case of a 35-year-old male who presented with complaints of abdominal pain. And on examination, there was a tenderness in the left iliac fossa and hypogastrium. Also, there was a mass present in this area. We did a digital rectal examination and we were able to palpate the base of a bottle with the tip of our fingers. When we further probed into the history, the patient revealed that he had inserted a bottle of fabric conditioner to his rectum for sexual gratification. So we proceeded with a lower midline laparotomy and sigmoid colotomy, and the foreign body was retrieved. That is the sigmoid colotomy being done with the bottle being retrieved. And as there was extensive mucosal injury, we did a transverse loop colostomy for the patient. Postoperative period was uneventful and we were able to discharge the patient. Next is a case of a 15-year-old female who is a non-case of psychiatric disorder who presented with complaints of abdominal pain and vomiting. And on examination, she had a distended stomach in the epigastrium, left hypochondrium, lumbar and umbilical region. We took imaging and from the imaging, the distended stomach was found to be due to trichobasor. We did an upper midline laparotomy, gastrotomy, and then the foreign body was taken out. And the hair had formed a huge lump in the shape of the stomach, and taking it out was indeed a challenge. Postoperatively, the patient was sent home after giving proper psychiatric evaluation and treatment. Next case is a 25-year-old male who presented with complaints of abdominal pain for 4 days, fever for 2 days. On examination, the patient had tachycardia, hypotension, and features of septic shock, and the abdomen was rigid and diffuse guarding was present. And chest X-ray clinches the diagnosis of perforation. After stabilizing his blood pressure, we took the patient to the emergency theater, and we, on exploratory laparotomy, we found that the patient had a perforation at the proximal ileum, and the cause of the perforation was found to be a nail that he had ingested. And we did a resection of the anastomosis of the proximal ileum, and we were able to find 13 foreign bodies from his abdomen, including multiple nails, multiple safety pins, paper pieces, and hairs in his in the resected segment. Unfortunately, the patient went into septic shock. We were not able to extubate the patient, and the patient expired 2 days after the surgery. Then we have a case of 45-year-old male who was referred from periphery as a case of bomb blast victim to our hospital. The patient, on examination of the patient had multiple wounds over the abdomen, and the abdomen had diffuse tenderness. Chest X-ray taken showed free gas under the diaphragm, and we took the patient to the emergency operation theater, and we did an exploratory laparotomy, and we found a perforation in the jejunum, and the cause of the perforation was a bombshell that was present in his jejunum. We retrieved the foreign body, and primer repair of the jejunum was done. Next is a case of 26-year-old male who presented with the features of perforation peritonitis, and the X-ray showed free gas under diaphragm, and when we did the exploratory laparotomy, we found that the perforation was caused by tapioca sticks that he had ingested few days back. We did the resection anastomosis of the ileum, and postoperative period was uneventful. Next is a case of a 35-year-old male who presented with a history of assault by some non-persons by inserting a bidet into his rectum. This is the image that the patient presented with. We had a 15 centimeter of the proximal part of the bidet sticking out per annum of the patient. As the parabulum was soft and non-tender, we did the CT of the patient and was able to localize the foreign body, and there was no bowel injury identified. So we proceeded with the removal of the foreign body through the anal orifice itself. Rectum and anal appeared to be normal. So we obtained a 35 centimeter long bidet with 15 centimeter inside and 20 centimeter outside the anal canal. Fortunately, the patient was post-operatively stable, and we could not follow up the patient because he was a migratory worker and went back to his state. Next is a 65-year-old male who has a history of accidental ingestion of denture while he was having food. Through serial radiographs, we found that the denture was impacted at the pyloric region. We tried endoscopic removal of the denture, but we could not retrieve it through endoscopically. So we did an upper midline laparotomy, gastrotomy, and the foreign body retrieval. And then is a case of a 30-year-old male who fell with a history of fell with a sewing needle in his hand, and the needle had pierced through his abdomen. We were not able to clinically identify any features of the needle, nor was it present in the radiographs. So we proceeded with the exploratory laparotomy, and the needle was retrieved from the posterolateral abdominal wall. So these are some of the 10 cases that we encountered during the last 2 years. But we found out that the absence of any standard guidelines for the management of these foreign bodies does pose dilemma regarding their management, and this increases to the morbidity of the patient. For variety of the foreign bodies encountered, the surgical intervention was laparotomy till date, but now with the multidisciplinary team, laparoscopy, with aids such as endoscopy and fluoroscopy, we are getting better results. That's all. Thank you.
Dr. Anju, thank you for the presentation.
Thank you, sir.
Regarding that needle, no?
Yes.
You said it was not seen on the X-ray.
Yeah.
Then what prompted you to do a laparotomy?
The patient gave a clear history, and clear history that it went into the abdomen, and the bystanders was also saying that the patient had pain over the site. So team was formed, and they decided to proceed with surgery and explore the site.
Do you think a lateral view would have helped?
Maybe sir. We took a lateral and this view, but we were not able to identify. Straight, erect view as well as lateral view was taken, sir. Yes, sir. Maybe, sir. No, it did not penetrate the abdomen. It was in the abdominal walls, sir.
Regarding the protocols for management of foreign bodies, once I read a case where a glass was inserted into the rectum, and then they used a very ingenious method to remove that. They put a plaster, POP into the glass, and then they could pull it down.
Okay.
So some ingenious methods were used in removing foreign bodies.
Oh, yes, sir.
The same situation happened when I was doing my MCH. One person from Gulf, actually he inserted some Coca-Cola bottle or something for some sexual satisfaction or something. And it went into the rectum and he could not retrieve. So he called a doctor in Kerala and he took the flight from Gulf, reached Trivandrum and took a room in the hotel. And the discussion was going on in the surgical gastro department, how to remove the foreign body and all. The same thing they were discussing. But in the evening, that patient said, "Sir, I got it," and he went back to Gulf.
After opening the pressure, we have pushed it.
One thing that is very commonly inserted for sexual gratification in foreign countries is the vibrator. So that is very common there in emergencies. Once in a while, maybe in a couple of months, you get one case where you see a vibrator, and the patient will come and you'll see a bruise on the abdomen because it's still vibrating. And then the first thing you got to do is to put your fingers in and off the switch. Sometimes surgical jokes. There was the person who swallowed this artificial eyeball. And then accidentally. And then the surgeon was doing a proctoscopy and then he ran out of the room. And then people asked him why. They are telling that this is the first time I have looked at so many bottoms. This is the first time a bottom is looking at me.
Emergency situation. Boy came to the casualty and with this was the days of the Vishu, that is the fire. Then this crater and this injury that he sustained on his chest wall. But it was taken very lightly initially, that he was taken to the dressing room, but there was something that had to suspect, that the patient became breathless after some time. He came by walking. So we had to do a thoracotomy. So foreign body could not be identified inside. So, but there was bleeding. And the bleeding that we went traced, we found that the diaphragm was coming from the inside the abdomen. And that diaphragm was torn. So it was on the left side. So that case then turned out to be thoracotomy and next laparotomy, and then we found that it was inside. The foreign body was impacted and within the spleen, that it ended up in the splenectomy. So the boy got discharged in 7 days' time. So that was an interesting incident. How the boy came to the OPS by walking, and he was then stage by stage that he was subjected to major surgery.
Thank you, Dr. Anju.
Thank you, sir.
The disgusting foreign body has made it an interesting discussion. Yeah. Thank you, the club members. Then now we will move into the main topic to dip in.
And Gobi sir was not able to make it because he was in Ernakulam now. So I request all the panelists, Rajan sir, Srijan sir, Rojan sir, Mohandas sir, to be on the dais, and Lakshmanan sir, and Lakshmanan sir, and instead of Gobi sir, KK Rajan sir, please be on the dais. KK Rajan sir. I thought that this session is mainly for PGs, and surprisingly I found even Fahim and Abdullah is there. They told they are very happy to see their teachers. And the number of PGs are as of now less, and as regular meetings, as the meeting progress, I think number of PGs will. I'll അല്ല മാധവൻ സാറും റസാൽ സാറും താഴെ നിന്നുള്ള interaction എല്ലാവരും actually can the seniors be on the front side? Pradhaban sir, Lakshmanan sir, Ramlal sir. Actually this I am basically a surgical oncologist. So for the first time when I saw all these, I also went behind the evidences, and surprisingly there are a lot of evidence for everything. I will project the evidence, and the wisdom part means that comes with experience only. I can just present the evidences. The wisdom comes from the most experienced people. So it's not just a panel, and I will be selecting few PGs to give their contribution also. I didn't tell prior because I know they won't come. So randomly I will select from here so that they can interact. I purposely didn't tell because it's an informal talk, not a formal talk. Surgical education is very different. It's not just learning. You need to attain surgical skill. And end of the day, so end of the day, you need to know how to do a case. So it's very different. I also remember when I joined for PG, the first thing I ask my friends is, cutting it, cutting it. That's only one aspect of the study. Probably the three main aspects is, one is doing cases, second is assisting more and more, third is theory and concepts, more emphasis. I had two phases. In MS General Surgery, I was in a more of an academic institution, Trivandrum Medical College, where cutting was extremely low. And when I did my MCH, it was in GCRA, where cutting was extreme. So I enjoyed probably the second part, the cutting part I enjoyed. Probably most of the PGs will enjoy that. But I would like Rajan sir to comment upon it. Is it that cutting everything, or what's your view about that, sir?
Thank you, Dipin, for inviting me to be a part of this group. You said it's not a panel. So, as a teacher who has survived in medical college for 4 years, I find that cutting alone is not the training part of a surgeon. Right? You have to know the basic aspects of the surgery. People think that surgery is only cutting. You have to have a sound theoretical knowledge as well before you can really discuss about cutting, right? Cutting part comes as once you probably acquire enough knowledge to deal with these situations, which I'm sure most of them would have acquired by the time they have appeared for the NEET PG, because they're preparing the theory part of it during the NEET PG. That's why they are not probably reading any textbook when they are coming to the postgraduate course. So ideally, unlike didactic lectures that has been taken place, today you have got the knowledge at your fingertips. So it's very easy to acquire knowledge. The only thing, there should be a passion to acquire that knowledge. Right? What I'm talking about is the theoretical, sound theoretical background based on which you start practicing the principles of surgery.
Okay, sir. I too, in my cutting phase, I had a mentor, Dr. Sadishan Balasubramanian. He told one famous statement, I can even make a monkey do surgery if he stays with me for 6 months. Probably that is true. And the sound theory and having an academic is very important. I will show the evidence later. This is famous model for achieving skills. Achieving skills is not it's not a personal thing. It's a person is not assessed, it's a skill is assessed. So skill can be developed. So there are 4 or 5 phases are there. There is a novice, then an advanced beginner, then there is a component, a proficient and expert. And our part of your residency is be competent to do. That's a third phase. You should reach the third phase. That doesn't comes along with cutting. That comes with what sir told. Like you should learn, you should know the sound knowledge of everything. And beyond that, it is the expert or proficient and expert. That's the panel which is sitting there. They are the ones who teach. So when you just see the history, I'm not just going into history. How residency started. This is the man who screwed us actually. Halstead. Actually, he copied from William Osler. Osler was the one who took his students for rounds and all. Halstead then joined there. He saw this. He adopted that. Then he started the Halstedian residency model. It's not like that. It's a very different model. I read and halfway I left. It's very different, but it's a basic framework of all residency program we have. So all my first 3 questions will be the most experienced one, Rajan sir. The past and present, probably when you were a resident or when Srijan sir was your trainee, and the present has lot of difference. Do you feel like that, or is it in a good way, or it's in a bad way? It's a change is there or not, sir?
Sure, there are changes observed, no doubt about it. Because the residency program, and in our time, I'm taking you almost 40 years down the line. It was quite different. We were sort of married to the board, full time. All the time we were in the board, taking care of the patients, discussing the problem with the unit chief, and sorting out the situations. And in case of any surgical intervention that is required, the chief will decide. And we get the experience from that particular decision making by the senior person. And he has got his own reason as to why this is indicated for a surgical operation or what. Okay. Today I feel that majority of the residents, particularly the third year residents, are on their own without being really supervised. So at which time they might think that they are getting the concept of no fear surgery, but sometimes they may lead into get into problems as well. Okay.
So you feel that change is good or bad?
Change is not good.
So one of my questions will be coming. It's a controversial question. I will put it in the last part. I will put that question last. I know the answer is sir is going to tell that only, so I put a controversial question in the last. Now, sir, in a nutshell, I think K.K. Rajan sir can tell. In a nutshell, what's the current scope of a general surgeon? General surgeon can prevail or not. This is an entirely different. One discussion is going to happen next 27.
So actually, as far as the general surgeon is concerned, I think the scope is decreasing. Because we do have all the specialities, and when we were taking this, when we were the beginners, we were doing all the specialty cases, including urology, neurosurgery, plastic surgery. All these cases were dealt by us. And under the persons and who were all expert in those fields. But now I think it has become reduced, and the surgeons, the scope is getting limited. Now it is something like, as we, what is said, we are getting, the field is getting expanded, and we are getting the surgeon is getting lessons and lesser chances. So the scope of the surgeon is getting limited to even small fields and like an abscess, or it's even something like that, drainage, or it's an emergency procedure, or like that. So we were at that time, even the neurosurgery cases, when it is a burial was being done by the general surgeon, and Dr. Vijay Nair once suggested, Professor suggested, that when the neurosurgeon is not available, it's justifiable for the general surgeon to do the keyhole and burial, not keyhole, burial. It is to save the life of the patient, because the burial can never kill the patient. So this was the attitude those times.
Recently, this same discussion happened in ASA group also. Now the legal liability, I don't know how.
Yes, exactly, that is correct. So now they will be questioned. So we can't handle those cases. It is being handled, and they will be questioned, and they may have to face the legal suits. So that is there.
I want to open this question to forum. Anyone in this forum believes that general surgeon has, Srijan sir, what is your view about that? My view after working in 3 years in general surgery, I will tell. Srijan sir, any contrary view or?
Maybe in the medical college,
Maybe.
it is a different scenario. Probably outside it is, the number of cases are shared by many. For example, if the thyroid surgery is done by so many people, like general surgeon, ENT surgeon, surgical oncologist, and endocrine surgeon, like that. So cases are shared. But we will not be able to compare the number of cases which we operate in the medical college and outside. Probably the number of laparotomies performed by the general surgery department is high, but at the same time the number of abdominal surgeries are less. And maybe the surgical gastroenterologist with that label, probably they can do more, and the general surgeon may not get a good share of it. Still, I believe that the variety of cases operated by the general surgeon, starting from the sebaceous cyst in the scalp to the ingrowing toenail, we have a variety of cases. We have good number of cases, even may not be in a corporate setup, but in the periphery, we get all those things.
So no one has gone to you, but all the PGs don't get depressed, those who are going to stuck in general surgery, because the next group which is going to come, they are going to definitely tell how to survive in general surgery. They are very confident that they can make you believe that you can survive in general surgery alone. They will be sharing their tips. This is the numbers to make you all scared. General surgery seats in government college is 77. All over in Kerala, there are 123 seats, MS general surgery, 36 DNB seats. If my max is not wrong, it's 166. Means per year 160 general surgeons are passing out. I'm not sure the job is there for them or not. There is a tight crisis. And still every medical colleges are trying to increase the PG seat. From 2009, it is 2019, 1,500, and 2023, it's around 2,000. Logic is very simple. Their concept. The tougher part of the job, that is night duty, paperwork, etc., has to be managed by someone, and less costly workforce is easily available. I had put that sentence. It may be correct, it may not be correct. Sir Mohinder sir, your view about this?
So it is directly related to the number of postgraduate and undergraduate seats. So there are too many people vying for the postgraduate seats. So naturally the pressure is on the system to increase the number of postgraduate seats. And there may be commercial interest also at play. So because of this, you find that one more issue is there. Why there are scrambles for the super specialty seats. Because in, I think, most of the countries outside, they call it as subspecialties, but it's a curious phenomenon in India where these are called as super specialties. None of the other countries are using that term. And because of this, you find that there may be specialists coming up for every part of your body like that. And the general surgery students may not get to see a particular procedure being done in a general surgery unit. Because when we were postgraduates, we used to see many so-called super specialties cases being done in general surgery. Their number has come down. So the next generation general surgeons coming out of our colleges may be seeing less and less of those cases. So that is a pity. They are not seeing cases like that. So then people will, they'll be feeling afraid to handle cases because of litigatory issues also. And then somebody might come in and ask, how many years of experience do you have in gastroenterology or something like that? Questions will crop up like that. Or how are you going to tackle that?
Probably the institute where I worked and in RCC and all, they are trying to increase the PG seats. The number of faculties are reducing. And probably in GCR it's one of daily 30 cases are operated and the teaching faculties are 5 and PGs are around 35. So they are making the work do with the PGs. Many situations, it's not similar in Kerala, it's totally different. Srijan sir.
Actually, in 2008, the total number of postgraduate seats for MS General Surgery was 1,480. And DNB seat was around 120. And after maybe 16 years, this has become 13,869 MS seats and 589 DNB seats. So that is the proportion it is going. So the number of seats are increased, and we know that even for undergraduate student, one professor post is enough for 250 students. And now for one professor can take 3 MS seats. It is not a demand based, or it's not according to the national standard. Probably in Kerala, the number of surgeons, or according to the population, it may be more. But in some areas, it need not be like that. In some areas, we don't see even MBBS doctors. So in other parts of India, probably there is demand, but in Kerala it is less.
That statistics I will put just, no, sir has already told that. I'll tell the answer. It's very well known fact that among the UGs, general surgery PG is not a popular course. They fear to take it. We should try to attract more people. There was a survey in 2015. That left side you can see, income. What will be the people's choice? Is it income, whether they are fit for that course? Option available to them is that only. They have money, financial issues, their role models, lifestyle. What prompted them to choose that? Can you guess what will be the answer be? Income? Answer. I have shown that. Your mentality, I know, obviously income will be the first one. I told for you. No? Few people are nodding. For females, I have a separate set of survey. I will tell the results, no issue. The result came as whether they are fit for that. That doubt remains for everyone. But the interesting fact, I noted that second most popular choice is role models. So if you are a very good role model, if a general surgery teacher is a very good role model, they are, I still remember Chandrashekhar sir telling Srijan sir name to, he was my role model from UG time. So maybe that can change a lot about that concept. And I regularly ask all house surgeons coming to our unit, do you want surgery? They want, the first answer will be no. What they tell is it's not an in specialty, lot of learning curve, life is hectic, their skill is doubtful, and the complications and others are difficult to manage with the family life. There is only one data published in 2020. In the 2019, you can see the numbers. 89 out of 100 chose non-surgical branches, and 79% of the top 500 chose non-surgical branches. Almost same data is, I don't have the exact number, this is followed everywhere. This is followed now also. And the most worrisome factor from them was existence of a general surgeon without MCH. Without MCH, I think everyone is thinking that it's very difficult to survive. So I will add one more thing. This is not a data. I called all the friends in here in Calicut. This is the current situation of super specialty in Calicut. MCH gastro, they are getting still opening for them. Their pay is still good. Ongo opening is there. Pay, I am not sure. They can survive with little bit of struggle. MCH vascular surgery is probably the most demanded. Probably Sunil sir will agree. It's very open now. Good pay. They can get independent consultant post. And MCH Euro, okay. It's very difficult to survive in Calicut city, but you can go to periphery and you can survive with a decent pay. And MCH and pediatric and plastic, you need a system to run that. Most of the time you can join as a junior consultant, but you can make money if you're ready to take night calls, or you can go to periphery and do some works. CVTS, I'm not so sure I don't know what's the status, maybe it will change. And MCH lab, endocrine, many things are there. So maybe probably except for gastro in Calicut city, survival of others is also difficult. So not only for general surgeon, for other people also. And there's one paper, super specialties, this is a data out, sir told, by 2023 there are 45,000 MS postgraduate seats. They are still increasing. But this is not the scenario in Kerala. This is all India statistics. Rural, still in the rural area, probably when I finished my MCH, I had an offer of nearly 5 to 6 lakh in GCR in a rural area, not in a city. So in rural area, in North India or above Kerala, we have a lot of openings still. And my view about that thing is general surgeons still have a scope. If you specialize in a particular area or laser or you do lab or you take up proctology, subspecialization, I think still have a role. Maybe when I was working government setup, it was different, probably private, I am not so sure. Sir, do you agree the fact that MS general surgery is now considered as a bridging degree between an MBBS and MCH?
No, I don't think it at all. Because you're going to disappoint all the people sitting here. Yeah, they're all, probably the general surgeon has got a definite role in this scenario. There is no doubt about that.
I will add one fact. Suppose you are going to choose neurology or neurosurgery or urology. What you do in a basic, what your basic things probably will change. Neurosurgery, all the general surgical things are not needed. So many people, especially in institute, they consider that getting degree is just a bridge to, they have good reading of everything, they will go to MCH. So now again, can you?
No, I don't think, because Rajan sir in 1992, he has given a book by ANAID, Making of the Surgeon, and the sentence which is given in that is, your selection of the subject has to be a choice. It should never become an accident. So if it becomes an accident, you will move on to different areas. And if you marry somebody whom you don't like, then you know what is going to happen. So similarly, you marry the subject, you marry general surgery, and probably that person will continue. I know that most of the postgraduates who complete MS general surgery will be moving on to specialties. But there are very few people who are staying back. But MS general surgery with another additional, as you said, proctology or laparoscopy or something like that, can actually improve the scope of general surgeon. And there are wide variety of cases which you can operate. Probably a urologist is going to get, as you were talking about income. Urologist may be going to get 70,000, 80,000 rupees in Calicut city. But the cardiologist is not going to get a salary of an MD person. you are not going to see MS general surgery people or MD general medicine to work in a hospital. But you will get hundreds of specialists, the so-called super specialists.
My view is that MS General is not a bridging degree. You have a lot of basics to learn that. Just for argument's sake, I put everything. You have a lot to learn in MS General Surgery, which my teachers taught me. It is still useful. Most of the things I learned in MS type is still useful for me.
But
Yes, sir.
it's almost, it's a simile that I'm bringing in. MS or the basic surgical training to have sound surgical principles. I mean, sound surgical principles, and particularly in, in the learning process, the student should be not learning by the chapters. They should be solving the problems. That should be the attitude of a teacher. That should be the attitude of the student. Because everything has to be taken as a problem and sorting out the problem. The other simile that I'm telling is that it is just like a house. You're building a house. The general surgery is the good foundation, right? You can have a nice living room. As you said, that you can probably go in for high-end laparoscopic training or specific field laparoscopic training. Okay, you can have a lovely bedroom where you probably get into some other specialty. You can continue. It's a continuing process of learning. Okay, so it all depends upon your passion. It's your passion to inculcate which subject you are really into. It doesn't come immediately after your residency program. No, it doesn't come. A surgeon's life starts at probably the age of 40, 45, no doubt about it. It's the training that you go through, leading into making complications, sorting out complications. This is all part of the general surgery training. Now, if you say that a neurosurgeon takes the 5 years course of neurosurgery alone, I'm still concerned that a neurosurgeon does a cranioplasty and sends to the general surgeon for fecal impaction. How do you feel it? Right? You put your bloody finger into it and you can dislodge the fecal matter. If that is the basis that you have learned, right? Today you find for a spinal tap, a medical patient is sent to the anesthesiologist. Worried about litigations? No, they're not worried about litigations. No, it's not that point.
I still remember my PG days when from medicine casualty consultation came for catheterization. Kindly catheter this patient. We wrote, we have arranged Foley's, we have arranged jelly, you please come catheterize, we will provide backup. So basics of surgeries, basics, you will have to learn that, and I think this is a message for all the PGs. MS is not a bridging degree, it's a very important degree. Selecting a stream of surgery, most of you had selected, there are many options, MS in a private or a government, DNB, or MCH 6 years directly. So MS surgery in a government and private, is it so different? Or if my initial concept is right, if MS is a bridging degree, it's okay. Or whatever about your view about that, sir? You have worked in both government and private. So what do you think? MS in?
MS, definitely MS is not a bridging course. That I agree.
Thank you, sir.
Then, regarding private sector and government sector, it has to be thought in different headings according to me. That is my thought. Nothing to hurt anybody. My own thought. According to the national policy, the government's now policies, the PG seats to be increased to equal to that of a UG degree. National policy. That is the central government policy now. And for PG admission, you should think about the pre-NEET PG period and post-NEET PG period. Before NEET PG entrance, NEET PG in the coming into the force, the government setup was purely admitted candidates
students purely on merit base. Whereas private sector, very few, Mangalore or in outside, not in Kerala, there it was, they can admit any student who are willing. That is their, up to their financial capacity, maybe their interest, of course. Now with the introduction of NEET PG, the scenario has changed. The government setup and the private sector, the candidate must be admitted only from the NEET PG list. Naturally, the government setup PG students joining are with a good score or good merit. And those who are not getting in government setup only join in private sector. The main reason is, as you told initially, the cutting chance. The student, whenever the student is joining, their first concern will be, where is the cutting chance? Even before joining in MMC, students will call me. Sir, what is the chance there? What is the scope there? Because I know nowadays in the PG list, all students appearing for the entrance coach list will be listed, and probably if the list is the 1 lakh or 2 lakh, the 2 lakh student also may be joining for the PG course. It is if the interested candidate joins, as Rajan sir said and Srijan said, a student with a passion who is not getting seat, if he is joining for a course, that should be encouraged. That should be encouraged. That's one thing I want to tell. And another thing is, in government setup, the students are now in Calicut Medical College, I think there is total 3 years means nearly 60 students. 3 years approximately. In other medical colleges there is more in government setup. Whereas in private setup there is only 2 students, 3, 2, 4 or maximum 6. That is what we are seeing. So naturally the private sector people, their main aim is to increase their workforce, to appoint less consultants, and all the job has to be done by the faculty. Whereas the government students, they will be, even though they are having more students, they will be getting more chances, but in government, private setup, chances will be less. The reason is that, one is the load of and variety of patients. As Srijan already told, the laparotomy done in private sector is very less. Even if there is no CASP, we can think what is the number of cases. I am telling in frank, only elective cases will be more done. Selected cases, that depends upon the credibility of the consultant. Not the patient coming to Calicut Medical College, not the patient coming to the Malabar Medical College. Patient is coming to Government Medical College, Calicut means it is coming to the medical college. So naturally, all types of cases will be done, all cases will be exposed, and the student is getting enough chance to learn, work up, learn and assist, and he get a supervision. Whereas in private setup, I cannot make a student to hand over a case and go away, because that patient is coming in searching of me. So naturally, all the consultants will be worried about the safety of the patient without any problem that patient has to. So naturally, the student has to be suffering. And another thing, one more, there is an advantage for joining in private medical college. Money factor, because the high-tech instruments, whatever high-tech instruments, because that's a corporate setup, they have to satisfy the patient. They will be bringing all the newer and the instruments they will be purchasing. That will be, the consultant will be going for special training, and they will be doing. And this PG who is not even doing a hernia case may be assisting all these cases, robotic or everything. Whereas in Calicut Medical College, a patient or student who is doing laparotomy right and left in the morning to till night and waiting for 3-4 days in the corner of a theater waiting for a slot. He will not be even able to touch the handle of a laparoscope. So after finishing the MS, the private sector people will be doing high-tech duties, and actually they will be more acceptable in the coming society because the people are high demanding, and especially when there is insurance and all this there, the people will be opting for all this technology-based.
Probably for all the PGs not to get worried by sir's thing for private sector, because my friend who did from a private and we did MCH together, now he's a robotic surgeon doing at least 20 cases per day, and I am still a budding laparoscopic maybe, or a somewhat into a laparoscopic surgeon. And probably second thing, I think Srijan sir will totally disagree, because Calicut Medical College harmonic is running through the ground. And
That is different because that is one person's interest.
Yeah,
He's
that's,
interested,
totally
he's
because
bringing,
of,
he's in the administrative post. That is, we know what happened before Srijan became the superintendent.
Yeah, in all the exact situation in Trivandrum Medical College, harmonic is in HOD's room. Even for a unit chief, it's very difficult to get that harmonic. Now, in here, maybe PGs are using harmonic now.
To be frank, I regularly get a bipolar only after I'm joining in Malabar Medical College.
One, now, this just not about MS and DNB. Now,
I think the state has changed because they will buy all new equipments to the government sector. Even a remote private government hospital, district hospital or a taluk hospital, they have all the HD laparoscopic system. It's not the problem of getting the newer technology, it's the problem of implementing it. I think in Calicut Medical College, all the department is having this, and even in all medical college, they have all facilities. But doing surgery in a private medical college, they are exposed more to these things. I think without doing or seeing an open case, how can you do a lap cholecystectomy? That's the basic problem, because we see a lot of injuries happening after laparoscopic surgery. Dr. Srijan was telling the scope of super specialist. I think I was called in for managing all the complications happening across general surgery department, but I have no issues in attending that. General surgery, because we have finished general surgery and joined MCA surgical, I have no problem. But the issue is super specialist or a subspecialist is required unless you don't have a trained.
in the AC group also, exact similar.
No, look, when you
But when you're well versed, I think a few surgeons in Ernakulam are doing everything. General surgeons are doing
no, that
everything.
means you are exposed or you are trained.
Yeah, trained.
No,
Obviously.
it's not the general surgery. It is your training which is mattering rather than when you are doing MS general surgery and you are going to get training proctology or laser and you are having an additional hand, because that is again a specialization, not the MCH degree which is mattering. It is your special training you get. And without getting a special training, an MS person completing 3 years and doing laparoscopy next day, how can you accept any issue happening out of it? It should be, what Rajan sir was telling is correct. When we were, we were the last batches of MS students when Rajan sir was, because after me there were four or five batches only. So we used to have evening rounds. Rajan sir himself comes. Nowadays nobody comes for evening rounds. Even in MOT or EOT, especially the senior PGs will teach the junior PG and they train from their senior PGs. So that situation should change. It's not the cutting alone. The PGs has to be trained properly, or they should know why you are doing this.
I have a very interesting data. I will show for this comment. I will have the comment after that. Sir, MS and DNB, is there any difference in Rojan sir? Because the patients are paying, they will be demanding for a consultant. Is it affecting the surgical training? DNB. Probably for DNB, I think, you can say.
Yeah, there is definitely a difference between DNB and MS because as already said, the people who are coming for DNB are people who obviously haven't got into the MS as per their rank. But that does not mean that they are anyway less interested. Some of them are even better than most MS candidates that we've seen, which we make out in their presentations, in conferences and on all that. The problem with DNB is that definitely the number of cases that the candidate gets to operate upon will be less. But I have done my training in government college, but after that I worked in a private medical college, CMC Vellore. And you wouldn't believe, when I went there, I was asked to operate on a thyroid. And I had seen many of them do thyroids. And I found that all of them are identifying the nerves and doing it. And I was asked to do a case. I said, I have a problem. I can't identify the nerve. Because I've never been taught to identify the nerve in my 3 years of training at Calicut Medical College. That was the norm there. Nobody used to identify the nerve. So the next step is that my immediate senior is not the person who teaches me to see the nerve. It is the professor who comes there to show me how to do the nerve. That is the difference. So if in a private DNB institution a candidate is taught a surgery, the senior most person is teaching you. That definitely is different between government and medical. I've been through both. I've been abroad also. It's the teaching in a DNB institution, if it occurs from the senior most person. That definitely makes the candidate at an advantage. There is the spectrum of general surgery in DNB in a private hospital is less because there will be gastrosurgeon, endocrine surgeon, oncosurgeon, everything. And I've realized that there is a problem with that. So I rotate these fellows for more than 6 to 8 months in gastrosurgery and oncosurgery. So they go through everywhere and with adequate periods of time. So I think that has to be done in every institution where DNB is done. You should not just keep them in general surgery alone. You must send them to other specialties for adequate time so that they get exposure and all that.
This is it's a paper, actually it's a review article is there, DNB, and I was surprised to get such a review article. They now it's equivalent, 2017 everything came equivalent, it's not different anyway from general surgery. And there is a list of comparisons, everything are matching, and one point is different, that what sir told, they are taught by a senior person. They are not taught by probably not a junior person, they are taught by the top end professor. That's given in that comparison. I never thought sir will tell that, I forgot to circle that. It is given in that. And they have tell one more thing. For them to pass in exam is difficult because they have no internal to support them. They have only externals. That was the difference they told. And maybe sir has answered as also problem of advantage of DNB. My friend, when I was doing MCH, he was doing DRNB in and probably when he finished, he did a robotic. I didn't even do a lab when I finished. So everything is there. So I will just skip one question. Sir, but
I think the selection of DNB in a private institute, because now we don't have DNB program in the medical colleges. So only in the private setup we have this. So a person who is going to select DNB in a private setup must be passionate. That's what I believe. Last time,
one thing I'll add, in MCH gastrosurgery, probably the first choice is DRNB Asian Institute. It's not
yes, definitely. So that person should be passionate. Last time, the first years were introduced, and most of the students said, my husband is in Calicut. Why did you select surgery as your subject? My place is Calicut. I have relatives in Calicut. And so these were the answers. I was really surprised. And again, I quote, the selection of the subject should be your choice. That was not considered. So a person who is going to do DNB, in my case also I can vouch that, because my interest was only surgery. The moment I was posted in the unit S2, where Professor K.P. Rajagopal was the unit head, And the first week I have made my decision that I am going to take up surgery only and nothing else. Even if I get MD free of cost, I am not going to take it. I am going to take only surgery. So the decision to go ahead with DNB is a different aspect. And those times the pass percentage was very low. It was 10 to 15%. Now we know that because of the OSCE, which is not properly constructed, the pass percentage has become 70 to 80%, or even more than that. Those time it was only 10 to 15%. So the chance of passing this, as you said, internals are not there. And when we write examination in any other place than our college, we cannot depend upon anybody. If you go to UK and write the exam, who is your internal? Or if you go to Sri Lanka, who is going to be your internal? So MBBS students used to say, നാളെ അലക്സാറാ വരുന്നത്, അപ്പോൾ അലക്സാറിന്റെ ചോദ്യങ്ങൾ പഠിച്ചിട്ട് പോകണം, അല്ലെങ്കിൽ ഗോപി സാറിന്റെ ചോദ്യം പഠിച്ചിട്ട് പോകണം. You can't do that in any other place than your mother institution.
Probably the answer will be, it's MS or DNB doesn't matter. It's your attitude, because what I feel that when I talk to DNB candidate, they are eager to learn more. I mean, they are after MS, after finishing MS, most of the people tell, ഞാൻ എല്ലാം UT ചെയ്യുന്നുണ്ട്, എനിക്കെല്ലാം അറിയാം. But DNB people are ready to go and gain more. They are going to other fellowship abroad, everything, whatever possible way they are doing. So it's not the degree, it's patient, it's the candidate's hunger that they come.
Well, I think nowadays the DNB candidates are there. Pass percentage is increasing.
Pass percentage is
increasing.
Last time I think everyone passed.
Earlier the pass percentage was very low, but somehow there are no residual persons remaining without DNB once they applied for it. It seems so. Whatever may be other problems that are mentioned here, the pass percentage is increasing.
Sir, Gobi sir.
So when they get good marks in OSCE, they automatically get pass mark.
It's very difficult to fail them, actually. I think now it's very difficult to. Sir, Gobi sir is absent. I think nearly 30%, 40% of the crowd is female. So the female surgeons are increasing. I will, Akshay, why did you choose surgery? You were the one who are nodding. I spotted you then and there. Why did you choose surgery? Passion. Yeah, so my that analysis was correct to an extent. Second is role model. Sir, Rajan sir, what's your view? Female surgeons are now increasing. I think I tried to call all female surgeons so that the crowd will be more of a female surgeon, but they most of them didn't come.
What Divin said is correct. So in our times we didn't have any the lady in the surgery department, and PGs were not there. It is true. Now there is one point I think is that somehow they want to acquire the PG degree. Now they know that undergraduates, just with the MBBS, this survival is going to be a bit difficult, and they want to attain a PG degree, and whatever may be the speciality, they want to go for it. I don't know how many of them are having the interest and the passion for the surgery. I am not very sure about it. One thing is that. Another thing is that even those people are coming, once they are getting in the field of surgery, then the interest is there, and they are becoming they are learning, and also they are becoming good surgeons. That is also true. And so this is, I think it must be the increase, the increase in the number of the aspirants for a PG degree. Even now, I think these departments like orthopedics, we don't find any ladies and in the orthopedics department. It seems so.
I have data for everything. Sir.
I don't know any orthopedic, anybody in the females in the orthopedics I have taken up.
Calicut there are two. Calicut there are two orthopedics.
I see.
In MMs there is the
And
orthopedic.
probably that will require some some strength and other things is required, and the field will be difficult for the ladies. That could be the reason.
Sir, I think everything has changed. I will show some interesting data about females. This is the gender difference. Right side is male. Left side is I took the screenshot wrongly. what is the cause of taking general surgery? First was personal interest for males and females. And for females, it's surprising. For males, sense of achievement was the ninth, probably ninth. For females, its sense of achievement was third. And for males, obviously, future job prospects and salary came at the top. And interestingly, I asked my wife, why did you choose anesthesia critical care? It all work-life balance and all. But the survey told that work-life balance is, for females, work-life balance is the last priority. I don't know when it is choosing, and after marriage it differs. So initially it's like that. And very interesting data. This is from the West. The most commonly chosen are plastic surgery, general surgery, ophthalmology, pediatric surgery, and breast. True. In Kerala or everywhere it's almost like that. Vascular surgery, no one is there as per the data. I think sir is having someone in vascular surgery in DRNB. No, someone. Actually, everyone, you can see that the pink thing. The pink thing is increasing, encroaching. It's very good to see. In every specialty, they are increasing. It's very good to see. And this is a very controversial. I am skipping there. The many people had many difficulties. I am skipping that. So now the interesting data. There is a study. They are just analyzing post-operative outcomes when it was done by a female or a male. For common procedure, not for uncommon procedure, maybe common surgical procedure. Surprisingly, female surgeons have a lower rate of post-operative outcomes. This data is not just this thing. This I think 13,000. They have evaluated 13,000 people. Next interesting data is referral from a male to a female. And the male physician appeared to have referral preferences for male only. Even in spite of having females increasing, the preference is still male only. When I thought I also used to refer to male, maybe it will change and the females will have a better hand. And we are not the people who are deciding whom should we go. The patient decides. The patient perception for female surgeon, there is, when the study told that patient doesn't have any gender base in selecting. If the skill and competency is good, they will select female. All these are data of nearly 15,000. So females have a very good prospect. It's very welcoming to see them. Lot of data, but this question is specifically for Srijayan sir.
In most of the batches, the present batches, the percentage of or the ratio of male to female is very interesting. 70% of the students, or 60 to 70% of the students are females, and maybe 30 to 40 are males. So definitely a proportionate increase in the selection of the subject also is likely to change. That's what I believe. One. Pradhananda Parayanala. Males. And the reverse naturally the selection changes. That is one.
Gender comment alla. When we did, there will be a ragging. We will have to give one letter to some females by. The senior will tell, go in. That time we had only very few to select.
In the classroom,
Now it's everything is.
even in the classroom itself, you can see that 90% of these are females. Only 10% you see these the males. Probably they find jobs better. Males they find job somewhere else better than this field. That could be the reason. That could be the reason.
Deepan, another thing. There are some male dominant specialties, like this we were talking about orthopedics, general surgery like that. Now in Calicut Medical College, the number of postgraduates or the entire postgraduates in the ENT department are females. And aggressive ENT surgeons or female surgeons are less. So there is some competition, but I don't think that our general surgery lady PGs are not like that. They operate. Definitely they operate. And similarly, we can compare the other parts of life also. For example, pilots. There are pilots who fly Airbus A380 and exclusively female pilot and the crew. So they are taking up all those areas. So definitely the surgical part also can be taken care of by our female surgeons.
Interestingly, when I search Google Scholar, there are entire at least 550, 60 papers they are comparing this, and all are favorable in females. I put only 2 or 3. This is specifically for Srijan sir. He is a superint. First year life is sleepless, hectic schedule. There things are collecting HPR, managing ICU, anesthesia fit ആക്കണം, things എഴുതി കൊടുക്കണം, വാങ്ങിക്കണം, ഇൻഷുറൻസ് റെഡി ആക്കണം.
This is purely for medical college. I don't think that this is applicable to any of the corporate hospitals because the number of staff nurses in Aster MedCity Cochin is 2,500 and the beds are 750. So it is 1:4. In Calicut Medical College, we require 4,500 nurses, but we have only 800. So that is the situation. So when we compare the number of staff in this hospital, it is much, much less when compared to any other corporate hospital. And then second one, you're talking about the collection of HPR and all those things.
Sir, my last question you didn't see. My question was specifically, these things, do it have a learning? I will tell my view. What's your view? Because
Yes, Sanal ഇവിടെ ഇരിക്കുന്നുണ്ട് ചെറിയ പ്രശ്നമുണ്ട്. Because whenever I start talking about when we were doing our...
Sir, our question last year.
So we can't say that അന്ന് ഇങ്ങനെയായിരുന്നു ഇന്ന് എങ്ങനെയായിരുന്നു എന്ന് പറയാൻ പാടില്ല. സനൽ എപ്പോഴും പറയും. അപ്പം ഞാൻ പറഞ്ഞത് ഇതെല്ലാം ഇപ്പം ഫോർ എക്സാമ്പിൾ കമ്പ്യൂട്ടറൈസേഷൻ ഇറ്റ് ഇസ് if a corporate hospital is about to start tomorrow, everything will be set today. But the e-hospital system and all these things are there in the dead stock for a long time. IAS officer is there. Record ചെയ്ത് അങ്ങോട്ട് പോയ പണി അതുകൊണ്ട് ഞാൻ പറയുന്നില്ല. Restrict my comments. So there are a lot of things. It too has a learning. Definitely there is. Insurance ready ആക്കണം അല്ലെങ്കിൽ arranging things. Blood. It's only because the system is running like that. That is the only reason, and it cannot be considered as a standard.
My comment is, I also think sleepless night, that thing I employed in practice also, that sleepless night helped me. Collecting HPR shows the relevance of HPR, and Gopi sir used to make them discuss. So, you know, you learn a lot from collecting HPR. You just write, but if you read and write, it will be more useful. Managing ICU, obviously when I am now in TCC, I am out of general surgery. I have to manage ICU.
Collecting HPR, I would like to tell, because ഒരു വര വരയ്ക്കാൻ മാത്രം ബാക്കിയുള്ളതുകൊണ്ട് the report HPR written there was malignancy, and actually the lymph node biopsy was not having. ഒരു വര മാത്രമേ മാറിയിട്ടുള്ളൂ, and patient got 2 cycles of chemo also. And then they realized the report was not correct. So അതുകൊണ്ട് there can be lot of clerical errors. എഴുതുന്ന ആൾക്കാരും മര്യാദക്ക് എഴുതിയിട്ടില്ല അത് സംഭവിക്കും.
Sir, I think Rajan sir will be the perfect person to answer, sir. Do you, I think everything, there is learning in everything, making anesthesia fit, arranging things. They will be knowing what all they need for a case. And making insurance ready, my personal experience when I went to PSC, the question was, what are the insurance scheme available for, now PSC interview, available for cancer patient. Since I know these things, I was able to tell at least 2-3 things. So everything had implication in my life. Everything was useful for me. So I think it does. Sir, Rajan sir, you're...
Everything you learn each day on different aspects are really important, no doubt about it. But my feeling is that whether it's first year of residency, second year of residency, or third year of residency, there must be a structured training for them. This is lacking. Let me be very frank about it. This is lacking. Whether they are first year or second year, they must be having a theoretical discussions. They must be having operative surgery discussions, journal clubs, etc. That particular structured program should exist in medical colleges. Enough and more staff is there to conduct it. Something which we say that yes, it is only finally boiling down to the process of cutting. Right? Before you cut, decide whether you have to cut or not. whether something has to be cut or not. That is very important. So I personally feel that all those things what you have written is perhaps, as Regent said, is in the setup of government hospitals. Because in most of the corporate hospitals, none of this insurance system work. Right? CASP and Casper or whatever be it doesn't work. Because they are there to make money only. So government setup, yes. But then they were telling about the sleepless nights, difficulties, stress, etc. Many factors are coming into discussion these days about the work pattern and the bullying of the juniors by the seniors, etc. I don't know, because we haven't tasted that before. So I can't be talking about that particular aspect, right? Yeah.
I want one first year, at least one first year. What will your ideal first year schedule be in your dreams? You can tell, it won't be possible. Any first year? And now I have to call the name. Ilsana. Mic. You can tell. At least Regent sir will hear. I don't know what will happen.
Actually, I'm okay with the schedule now.
Ara, failure, ara. Not.
I took surgery with 100% plus passion. I want to be a vascular surgeon. So.
Vascular surgeon?
Yes. So I'm really okay with this
that blue
system.
will become pink from one side.
And as I have already mentioned to Srijan sir once, that even without any family support, I took surgery, and I did my house residency in the same college. I knew most of the APs, earlier also. So I worked with Divin sir. I remember my internship. Even then also I did HPR collection. I learned more from HPR collection. I even discussed HPR reports at the internship time. So doing that in first year is not, I don't think it as a time consuming thing. Alla, actually adinum time vanam. Usually we used to collect it at pre-admission day. Pre-admission day we will have time for that. Appam adu prashanilla. The oru karyam matram insurance ready.
Okay, so you're happy with your first year schedule?
No, the thing is insurance. Adu matram enku oru prashanayittu thonnitullu. Because adu as a JR1 nammal varunne ullu. ഒരു കോളേജ് സിസ്റ്റം മീൻസ് ആസ് എ സിസ്റ്റത്തിലേക്ക് നമ്മൾ കടക്കുന്നേ ഉള്ളൂ. അപ്പോൾ ഓരോ പേഷ്യൻറ്റിൻ്റെയും എന്താ പറയുക, അവരെ വീട്ടിലെ സാഹചര്യം നമുക്കറിയില്ല. ബട്ട് സ്റ്റിൽ ചിലർക്ക് ഈവൻ ദോ ദേ ആർ പുവർ ദേ വോണ്ട് ഹാവ് ഇൻഷുറൻസ്. അപ്പം നമ്മളത് ഇവിടുന്ന് റെഡിയാക്കി കൊടുക്കാൻ ഇറ്റ് വിൽ ടേക്ക് ഓൾമോസ്റ്റ് സർ ഐ ഹാവ് സ്ട്രഗിൾഡ് ഫോർ ദാറ്റ്. ഈവൻ ഐ ഹാവ് ക്രൈഡ് വൺസ്. കാരണം എനിക്കത് റെഡിയാക്കാൻ പറ്റുന്നില്ല. ബട്ട് ദ പേഷ്യൻറ്റ് ഇസ് നോട്ട് ഗെറ്റിംഗ് even no medications at all. Sir, for 48 hours and all, patient was struggling there for insurance. 48 hours after admission. അപ്പം നമുക്കൊന്നും ചെയ്യാൻ പറ്റുന്നില്ല. ഞങ്ങൾ എന്താ ചെയ്യുക, വീട്ടിൽ നിന്ന് കൊണ്ടുവരണോ, ഇൻഷുറൻസ് റെഡിയാക്കാൻ അവരുടെ അടുത്തൊന്നുമില്ല. ദേ ഡോണ്ട് ഹാവ് എനി ഡോക്യുമെന്റ്സ്. അപ്പം അതൊക്കെ ഫസ്റ്റ് ഇയർ അതായത് നമുക്ക് ചെയ്യാൻ പറ്റാത്ത എനിക്കറിയില്ല.
Except maybe insurance, everything is okay. I think that should be okay for everyone, because it should be okay because there is lot of learning in that. PG Mohandas sir, എന്തെങ്കിലും ഒരു സാറിന്റെ കൺസെപ്റ്റിൽ ഒരു സാർ ഇപ്പോൾ എല്ലാ പവർ ഉണ്ടായിരുന്നു.
Apart from the insurance issues and all like that, what I feel is that the first year post-grad students should have a good grounding in anatomy and the basic sciences. There should be a little bit stress on those things, which I think very sadly forgotten nowadays. So somebody was cringing about these collecting HPR schedules and all like that. Sometimes, we had a situation where a patient who had biopsies with the same name, 2 people were there, and it was transposed. The person who collected it wrote the wrong diagnosis for the normal person, and then they were brought to the breast clinic, and then they suggested surgery like that. And then it took one relative of that patient. He came and met me and said, sir, this is, I went to the pathology and found out that the diagnosis was wrong. And they are going to make a big scene there. Finally, I consoled him and told him that you are talking about your own parent institution. You worked in this institution, and then, so somehow he was consoled like that. So I think a little grounding on these things also is needed for you. In addition to your duties and other responsibilities, these also matter. I also went through the same, I did my MS in general surgery in Trivandrum Medical College, where, as Devin knows, how are the chances there?
Yes.
We know very well. 3 years, and I learned all my surgery from Calicut Medical College after joining here, after MS. And this was the place where I learned all my surgical skills. And sleepless nights, I think it is part of the training. Sometimes, the patients don't come at 10 a.m. in the morning. Some of them, by the time they are worked up, it will be night. And you'll be woken up suddenly at 11:30 or 12. You may have to do the surgery till 4 o'clock or something like that. And don't say that I didn't bargain for this. I want to lay a day case surgery like that. No, it is not like that. Like the gynecologist complaining that all the children are born after 2 a.m. and all like that. So these are things you should be bargaining for. And you should be taking up all challenges also. Surgery is not like 10 a.m. to 4 p.m. work. That is what I'll tell that. And I'm not quoting that it was not like that in my days and all that. It's not like that. So there should be some difficulties and all like that. Learn it the hard way.
Probably that's a consensus. Learn it the hard way in the first year. Next years will be easy for you. Second year, Jawahar, have you decided your super specialty after second year? Abhilash.
Sir, I have finished almost all the major postings now. I went to all the postings with my full heart. I worked everywhere. And before going, I had it's in surgical, onco, and gastro. But after going, I have been totally confused. I liked all the specialties. So I don't know what I will do now.
I think second year, I think everyone will agree. Second year is a too short period to decide your super specialty. Probably after SRship or after the course. Srijan sir, any comments, sir?
I think it is not after the second year posting one to decide whether we should go to neurosurgery or urology. Even before that, people decide. And one person came from UK for his 2-3 weeks training, and he was a pre-medical man. He said, I'm interested in cardiology. And I said, you have not joined for even MBBS? And he said, I'm interested in cardiology. I thought it was a joke. And he opened his iPad and showed me 900 angiograms. So he was really passionate about cardiology, and he's going to take up cardiology, or he was thinking about cardiology even before he joins the medical college. So I don't think that it is second year which is going to decide these things. The decision can be, or probably in a doctor family, the son of Rajan sir must have decided to become a surgical gastroenterologist probably at the age of 5. Because things are different. I come from a family where there are no doctors. So the decision of the surgery taken by me is my own, and it is at 3rd semester. So things are different. It is not at second year or after training. Maybe after training, a few people are going to select cardiothoracic surgery, which is not taken up by many. Or surgical gastroenterology by too many people who is interested in this. So I don't think that there is a cutoff like that, or people are going to decide everything in second year. But they should be exposed to all the specialities, and they should get at least, Rajan sir was talking about the basic building or the basement construction. So that can be done in the second year by rotating in all specialities.
Now,
Sir, I think sir, I am now in oncology. I will also tell the same thing because I want manpower. But what they say is that they would like to continue in a specialty they like. For example, gastro, many people tell gastro, even though SAR is very irritating. So everyone like to continue in gastro because they are seeing a lot of things. There is their preference actually, and it's hard to decide.
Nowadays, the students take their decision for specialty even before joining PG course, because the new CBME curriculum, they have a separate elective is provided, and their preferences, and they, when I asked them, they, as Rajan said, I prefer to become a cardiothoracic surgeon, or I want to become like the, because this, they have taken decision even before joining the PG course nowadays.
I want one final year. Yadu? Yadu, just quickly. Time is short. Working under a single chief, will you prefer that?
No, sir. Actually,
no.
What I meant is we have to work under different unit chiefs. Everyone have got their own specialization. Some.
Okay, your answer accepted. I will just give a scenario. In Tamil Nadu, it's not like that. 1 minute. In Tamil Nadu, it's not like that. It's not. You will go to a chief. If the chief is good, your career will be flying high. That chief will be a big shot. You will be working 3 years under it. 3 years under it. And after the end of 3 years, you will be in some another level. That chief will treat you as a son. If you make mischief, then you will be gone. But if you are able to make that chief happy, you will be flying like that. So, what do you feel now?
In my previous institute where I studied MBBS, there are different units. Each unit is specialized for a particular, for example, unit 1 for breast, unit 2 for thyroid, like that. So what happened is I used to see my seniors complaining. Like once a fellow would be stuck with the breast unit, for the entire 3 years he would be in that unit. Recently only the rotationers came in our previous institute. Actually what I'm saying is in our institute, like all like different units, they have got different specialization. When I'm in Srijan sir unit, there was a lot of CA esophagus cases. Like we could see that, like sir is more inclined to that. And in different units, there are different, what we can say, different like.
Accepted.
Yeah. So anyway, we want exposure.
Okay, I think everyone will be of the same opinion. My second question, നമുക്ക് ഇങ്ങനെ ഒരു കൺസെപ്റ്റ് വേണോ? ശ്രീജൻ സാറിൻ്റെ യൂണിറ്റിൽ ഇപ്പോൾ വർക്ക് ചെയ്തെങ്കിൽ സാർ എൻ്റെ അടുത്ത് ചോദിക്കുന്നു, ആർ യു കോൺഫിഡൻറ്റ് ഓഫ് ഡൂയിങ് ദിസ്? നിന്നെ കൈപിടിച്ച് ചെയ്യിപ്പിക്കുന്നു. അങ്ങനെ ഒരു കൺസെപ്റ്റ് ഹാപ്പിയാണോ?
സർ കൈപിടിച്ച് ചെയ്യിപ്പിക്കുന്ന അങ്ങനെയല്ല സാർ.
കൈപിടിച്ച്
കൈപിടിച്ച് സാർ അങ്ങനെയല്ല ഉദ്ദേശിച്ചത് സാർ. ബട്ട് എക്സ്പോഷർ വൈസ് സാർ, ഇങ്ങനെയാണ് ചെയ്യുന്നത്, ഇങ്ങനെയാണ് പ്രൊസീജിയേഴ്സ്, ഇതാണ് ചെയ്യുന്നത്, അതൊക്കെ കാണാൻ പറ്റുന്നുണ്ടല്ലോ. കൈപിടിച്ച് ചെയ്യിപ്പിക്കുന്നത് തേർഡ് ഇയർ അത്ര എക്സ്പെക്ട് ചെയ്തില്ല സാർ.
Sir, is it possible that the faculty should ensure that for example, you are passing general surgery, you should be aware of hernia, thyroid, breast. When I passed MS, I was not confident of doing a thyroid. So, is it the role of teachers to make sure that all the things, or such a system should be adopted?
I think what Yadu said was right. When in your base formation, you should see different unit chiefs, their attitudes, their good and bad. They should be able to pick up. നെല്ലും പതിരും തിരിച്ചറിയാന്ന് പറയില്ലേ, അതുമാതിരി അവർക്ക് അറിയേണ്ട പ്രായമായി. They should know. Some of them may be miserable, some of them may be very good, right? So they have to see the good, bad, ugly aspects of everybody, number one. Now, when they are doing an SRship, this is the basic training program I'm telling, that they should see different paper. They should be working under different paper. But being an SR, perhaps, they can be stuck to a single unit where probably they will develop one of those speciality that particular unit is interested in. This is my view.
I will call one SR also. Satish. Satish, that third question is probably for you. Do you feel after finishing your MS and now you're in a SRship, instead of open surgeries, then I will ask Pradhaman sir's comment also. You should be taught more in a laparoscopic way or you should be taught in an open way? You are now mature enough, pass enough, you can have your comment.
I think we should know both open and lab, because when we go outside, if there is no lab, if some complication happens, we should be confident to open.
No, അങ്ങനെ ഒരുമിച്ചെല്ലാം കൊണ്ടുപോകാൻ പാടായിരിക്കും. First year lab training ആണോ better അതോ?
No, we should know first do open surgery, then we proceed to lab.
Okay. Pradhaman sir. Lab ആണോ ആദ്യം പഠിക്കേണ്ടത് in current scenario? For example, typical example, hernia anatomy is different in lap and open.
There are some surgeries in which laparoscopy is the standard. So you have to learn those standard. Laparoscopic cholecystectomy, I think that's the standard. You don't have to do open cholecystectomy because you don't have laparoscopy, no. But there are some surgeries like Whipple's. Laparoscopy is not the standard even in the best of the centers. So I think they have to learn the basic laparoscopic surgery where laparoscopy is going to be the standard or is the standard, right? They have to get trained in laparoscopic cholecystectomy, the critical view and all, the important steps, etc. during their period. And they should be able to put trocars, able to do laparoscopic appendicectomy. And hernia, I don't think even Dr. Srijan won't agree laparoscopy is the standard procedure. Okay, so doing everything laparoscopically is not agreeable, but you have to have basic training in basic laparoscopic surgery.
The view that will come in next meeting is probably the survival of general surgeon outside depends on hernia. Lap hernia.
No, even surgical gastroenterologists are outside government medical colleges surveys based on these surgeries. I think general surgeon is not safe even with hernia when others are doing laparoscopy. Don't think like that.
I'll just, time is short, I will quickly move through this, right? There is a self-maintained hierarchy in residency. Final year വിചാരിക്കും second year എൻ്റെ താഴെയാണ് അത് it's a good trend or a bad trend? Lakshman sir.
Previously there was no hierarchy among PGs. Previously
ഇല്ലായിരുന്നു.
Suddenly it appeared because previously നേരത്തെ ശ്രീജയന പറഞ്ഞത് ഞങ്ങളുള്ള കാലം പോലെ പറയാൻ പാടില്ല എന്ന് പറഞ്ഞത്. എന്നാലും ഞാൻ പറയുകയാണ്, എന്നോടല്ലല്ലോ പറഞ്ഞത്. ഞങ്ങൾ പി ജി ആയ സമയത്ത് ഫസ്റ്റ് ഇയർ, സെക്കൻഡ് ഇയർ, തേർഡ് ഇയേഴ്സ് എല്ലാവരും എല്ലാ ജോലിയും ചെയ്യാനും വാർഡിൽ എല്ലാ സമയത്തും ഉണ്ടാവും 24 hours. ദാറ്റ് വിൽ ബി സൂപ്പർവൈസ്ഡ് ബൈ സീനിയർ ടീച്ചേഴ്സ്. മാധവ് നമ്പ്യാർ സാർ, രാജൻ സാർ, എ കെ രാജൻ സാർ, റസലൻ സാർ, everybody will be taking. P. Rajan sir will be always roaming with a scooter. Whenever he come to the Devagiri, invariably he will enter the casualty and he will see what we are doing. We will be under supervision and we are confident also. Nowadays, unfortunately, what happened is I heard about, I don't know whether it is now present nowadays, the first year PG has to give an induction party. I don't know whether it is there nowadays. After that, then only the senior PG will allow him to, will teach him. Because the first year PG has to learn from the senior PG. Second year PG will be going for specialty and the third year PG. The first year PG will work up everything and the patient will be ready and on the table with the mobile phone ringing. The PG, senior PG will come and he will do the case and go away. What is and this is happening. But nowadays, what is I heard. But previously, There will be, the MO will be in the ward, he will be in the upstairs, or he will be in the ward side room. Whenever we need, he only under the supervision. We used to do cases, but it will be only under the seniors. Experienced teachers will be always there. Nowadays, teachers are also, I am not don't want to be, Prathapan know better that, how we stayed and how we did everything. So this hierarchy maintaining is very bad for the surgical career development. That is what my opinion. But there is one positive point. The first year PG will get a high confidence he will get. He will dare to do anything because his knowledge is less, his experience is less, and he will think that the same thing is that. And he will be teaching the same to his junior PG after some time.
Probably ABA was my first year. Our dictum was we used to make them do cases and go for a party. It is followed everywhere. I think to an extent it's okay, I feel. There are two types of that. This is a paper. There is a functional and dysfunctional. Functional is optimum. To an extent it's okay. It's good. It's good for patient care. Dysfunctional is when you go too bad, like something happened in ortho. When it go too bad, it will be, I think, not good. So I think it can exist to an extent. Opinion of all persons, maybe it's not possible. Surgery is all about cases. You have to do case. It's just assisting or just observing, or what your aim should be focusing on basic anatomy and doing cases in large number, or assisting the residents and make him do or allow him to operate independently. There are various things there. I am not going in detail. I'll just show the evidence of that, or quickly Srijan sir. Independent.
എനിക്ക് തോന്നുന്നു ഞാനൊരു ഗുഡ് എക്സാമ്പിളാണതല്ലേ, ബിക്കോസ് ഐ ബീൻ ട്രെയിൻഡ് ബൈ രാജൻ സർ, ആൻഡ് ഫോർ യുവർ ഇൻഫർമേഷൻ, ഫോർ ദി ഫസ്റ്റ് 4 months ഐ ഹവ് നോട്ട് സ്റ്റിച്ച്ഡ് ഈവൻ സ്കിൻ, ബട്ട് ആഫ്റ്റർ ദാറ്റ് വാസ് എ ടെസ്റ്റ്. അത് കഴിഞ്ഞതിന് ശേഷം എല്ലാം, എവറിത്തിങ് സ്റ്റാർട്ടിങ് ഫ്രം സെബേഷ്യസ് ടു ഇസഫാഗസ് ഹി ഹാസ് മെയ്ഡ് മീ ഡു. അപ്പോൾ ആ ആദ്യത്തെ 4 മാസം എനിക്കറിയാം, ആ സമയത്ത് അടികൂടിയിരുന്ന കുറേ ആൾക്കാരുണ്ടായിരുന്നു. അപ്പൻഡിക്സ് എനിക്ക് ചെയ്യാൻ കിട്ടിയില്ല. എവറിബഡി വാസ് ഇൻട്രസ്റ്റഡ് ഇൻ ദ തിങ് വിച്ച് യു വർ ടോക്കിംഗ് അബൌട്ട്, cutting and cutting. But assisting and doing it under supervision and performing surgery, 3 stages has to be there, and everybody should assist maximum number of cases, and I have learned a lot, and there is no doubt about that, by assisting. And I always tell all my postgraduates that you should call for help at some point. Call for help, call for help, call for help. Because if you call for help at a particular point, you will know how the other person comes and manages that situation, and probably that person will be doing it in no time, and the person who is operating can take hours for that particular procedure. So always call for help, remember that, and assist maximum number of cases. എനിക്ക് തോന്നുന്നു രായൻ സാർ അതിൽ അഭിപ്രായം പറയണം.
I think I would rather echo his statements, right? As rightly said that you call for help, right? There was a guy stuck with a knife on the epigastrium, and I told the postgraduate student, don't pull it out. It's an impaling object. Don't pull it out. He was so inquisitive that he took in the theater, he just pulled it out, and then the alarm started, right? And that was a ventricular injury, which neither the MO on duty could manage, nor that particular guy who pulled out the knife, right? So then we had to show them how to manage a ventricular injury.
I will slightly differ. It's okay. I have been assisting thyroid for a long time, MS. Lots of thyroid I haven't done. I finished in MCC, then I went to GCRI. There also I stood maybe 4 or 5. Till the point I did my first thyroid. I tried in SR-ship, I was not able to do. But when I did in MCH, that's the time I was happy, or I was feeling confident that I can do thyroid. Then after coming here, still I struggled with a lot of thyroid. So there is a lot of learning. Once you start beginning for advanced cases, there is a lot of learning. That comes by assisting only. There is an interesting study. There is a study that what's the outcome of patients who was operated by PGs alone. I think what will be your data? There's a large number of cases. They three groups, they residents by surgeons only, performed by residents, assisted by surgeons. And interestingly, procedures done by resident alone was not associated with any much morbidity or mortality or no complication. But the interesting thing is that there is another study also. Your skill and your performance to do alone comes with time, and probably in US and all it's 5 years. So it comes with time only. So I think you should assess and then only learn. Sir, last question, probably 2 or 3 slides are there. Rojan sir, in the DNB center, probably it's a lack of hands-on.
Yeah, definitely there's a lack of hands-on. So the only way is to, even for private patients, you have to assist your PG, take time. You need more time to make somebody do. That's the only way out. We used to have this ECHS schemes at one point where you get patients who are not paying. At that time used to be better, but we are managing it. You can ask one of the DNB candidates.
Anashwara.
Yes.
I messaged him to come. Yeah. Anashwara illa?
Yeah.
I mean, just forget that. How do you feel you are doing DNB? I think you are third year. Second year. Third year undo? Third year Shani there. Shan. Right. How do you feel after 3 years of DNB?
Sir, the cutting chance is definitely low. Lesser compared to government medical college.
But do you feel confident to go out and?
Yes, sir, I am confident actually, because I have assisted almost many thyroid cases. With Rojan sir alone, I have assisted. With Rajan sir, I have assisted. I think I am confident. Each step they will show you how to do. In every step, he will make you do. From the skin to the platysma, he will make us do. ഒരു കേസിൽ ഒരു പ്ലാറ്റിസ്മ വരികയാണെങ്കിൽ നെക്സ്റ്റ് കേസ് ഒരു recurrent identification he will make us do. So each step they are assisting. Every step, എനിക്ക് ഓർമ്മയുണ്ട് സാർ ഒരു even subcuticular suture, he will make us, he will watch us. ഒരു ചെറിയ മിസ്റ്റേക്ക് വെച്ചാൽ he will redo it, make us redo it. So
this was exactly what is given in that paper also. The DNB, your training will be more stringent. ഇത് എനിക്കൊന്ന് ലാസ്റ്റ് സ്ലൈഡ് ആക്കാം. സനലായിരിക്കും ഇതിന് ഫസ്റ്റ് പറയേണ്ടത്. There is a concept that ഞങ്ങൾ പണ്ട് ഇങ്ങനെ ചെയ്തുകൊണ്ടിരുന്നത്, ഇപ്പോഴും അത് ചെയ്യണോ സനൽ?
വിസ്ഡം കംസ് വിത്ത് എക്സ്പീരിയൻസ്, അതിലൊരു സംശയമില്ല. നമ്മൾ പ്രൊഫഷണൽസ് ആണ്, പ്രൊഫഷണൽസിന് എക്സ്പീരിയൻസ് വളരെ കൗണ്ട് ചെയ്യും. പലതും പഴയത് തന്നെ ചെയ്യേണ്ടി വരും. പക്ഷേ ഞാൻ ടെക്നോളജി നമ്മൾ ഉപയോഗിക്കുന്ന കാര്യത്തിൽ, മെഡിക്കൽ കോളേജ് സംബന്ധിച്ചിടത്തോളം ടെക്നോളജി ഉപയോഗിക്കാത്ത കാര്യത്തിനാണ് ഞാൻ എപ്പോഴും പറഞ്ഞുകൊണ്ടിരുന്നത്. നമ്മളിപ്പോഴും HPR കളക്ട് ചെയ്യുന്ന കാര്യവും മൈക്രോബയോളജി കളക്ട് ചെയ്യുന്ന കാര്യവും അത് എസ് PGസിൻ്റെ കാര്യത്തിലല്ല, പേഷ്യൻ്റ് സെനാരിയോയിൽ നമ്മളെപ്പോഴും പേഷ്യൻ്റെ ഭാഗത്ത് കുറേ ബുദ്ധിമുട്ടുകളുണ്ടല്ലോ, അത് വെച്ചിട്ടാണ് സംസാരിച്ചുകൊണ്ടിരുന്നത്.
അല്ല, നമ്മളിപ്പം സാറുമാരില്ലാത്ത ജൂനിയർ APസിന്റെ ഗ്രൂപ്പിലും നമ്മളും ഡിസ്കസ് ചെയ്യാറുണ്ട്. അത് പണ്ടങ്ങനെ ചെയ്യുന്ന പറഞ്ഞാൽ നമ്മളങ്ങനെ ചെയ്യണമല്ലോ, ചെയ്യണ്ടല്ലോ.
ഇല്ല, ഞാൻ ശരിക്കത് ഞാനിപ്പോൾ മെഡിക്കൽ കോളേജിൽ വന്ന് 3 വർഷം ആകുമ്പോഴത്തേക്ക് എൻ്റെ തന്നെ തോട്ട് പ്രോസസ്സ് കുറച്ച് മാറിപ്പോയെന്ന് എനിക്ക് തോന്നുന്നുണ്ട്. എന്നുവെച്ചാൽ ഞാനിപ്പോൾ വിചാരിക്കുന്നത് ചിലപ്പം പഴയത് ചെയ്തത് അത് അത്രയും കാലത്ത് ഒരു മെഡിക്കൽ കോളേജ് റൺ ചെയ്യുന്നതിന് ഒരു റീസൺ ഉണ്ട്. അതിന് അങ്ങനെ ചെയ്യുന്നത്, മെഡിക്കൽ കോളേജ് അങ്ങനെ റൺ ചെയ്യുന്നതിന് റീസൺ ഉണ്ട്. നമ്മൾ സ്റ്റുഡൻറ്റ് ലൈഫിലല്ലേ മെഡിക്കൽ കോളേജ് കാണുന്നുള്ളൂ. അത് കഴിഞ്ഞ് ഇപ്പോൾ ഫാക്കൽറ്റി ആയിട്ട് അതിന് പ്രോഗ്രസ് ചെയ്യുമ്പോൾ മെഡിക്കൽ കോളേജ് അങ്ങനെ റൺ ചെയ്യുന്നതിന് റീസൺസ് ഉണ്ട്. അത് അങ്ങനെ നടക്കുള്ളൂ, അത് അങ്ങനെ വേണം താനും. നമുക്ക് ഒന്നാമത് നമുക്ക് ബേസിക്സ് നമ്മൾ കാണുന്നത് ജനറേഷൻസ് നമ്മൾ കാണുന്നുണ്ട്. അപ്പം നമ്മൾ ബേസിക്സ് നമ്മൾ വീണ്ടും വീണ്ടും സ്ട്രെസ് ചെയ്യേണ്ടി വരും. നമ്മൾ ബേസിക്സ് മാത്രം സ്ട്രെസ് ചെയ്യേണ്ടി വരും. വളരെ അഡ്വാൻസ് ആയി ചെയ്യുമ്പോഴും നമ്മൾ മുമ്പ് പറഞ്ഞ കാര്യങ്ങൾ സ്ട്രെസ് ചെയ്യേണ്ടി വരും. അത് സാറ് പറഞ്ഞ പോലെ സ്റ്റെപ്പിംഗ് സ്റ്റോൺ ആണ്. നമ്മൾ ചെയ്യുന്ന നമ്മുടെ ജോലി എന്ന് പറഞ്ഞാൽ നെക്സ്റ്റ് ജനറേഷനുള്ള പ്ലാറ്റ്ഫോം ഉണ്ടാക്കുക, ബേസ് ഉണ്ടാക്കുക. ഇതൊക്കെയാണ് മെഡിക്കൽ കോളേജ് ഫാക്കൽറ്റി നമ്മളെ ജോലി. അപ്പോൾ നമ്മളത് സ്ട്രെസ് ചെയ്യണം. പക്ഷേ ടെക്നോളജി യൂസ് ചെയ്യുന്നതിൽ നമ്മൾ പുറകോട്ട് പോകാനും പാടില്ല. നമ്മളിപ്പം AI വരെത്തി നിൽക്കുന്ന സമയത്ത് ഇപ്പോഴും ചില കാര്യങ്ങൾ വീണ്ടും നമ്മൾ ചെയ്യുന്നത് മാത്രം.
ബേസിക്സ് ഷുഡ് ബി പണ്ട് പഠിച്ച തന്നെ പണ്ട്, കുറച്ച് ടെക്നോളജിയിലോട്ട് പോകുമ്പോൾ ഷുഡ് അഡാപ്റ്റ്.
അതെ അതെ അതെ
ശരി.
Those days, the patients were managed. Nowadays, media, work attitude, so many things changed. So people are more demanding. You know, the caste system is a simple example. So they actually won't collect any prices for the surgeons. So if you do a Wippers procedure in means, or any program, it comes to around 4.5 lakhs final bill. Here they give you 30,000. We are made to do Wippers research, and the next day, I don't have this, you know. So they will ask, sir, why is there many mistakes? They are not looking at the professional service which we are giving. So the people have become more demanding. And the same thing happens to the PG teaching and all the other aspects. So you have to improve your technologies as well as you have to make your PGs how to handle new generation of patients.
ഒരു കാര്യം കൂടെ സാറ് പറഞ്ഞ പറയാണ്, നമ്മൾ ഇപ്പം ശ്രീജൻ സാറിന് അല്ലെങ്കിൽ ഇപ്പോൾ സീനിയർ ഫാക്കൽറ്റിക്ക് ഉണ്ടാവുന്ന ഒരു ഫ്രീഡം സത്യം പറഞ്ഞാൽ ജൂനിയർ ഫാക്കൽറ്റിക്ക് ഇല്ല. നമുക്ക് ഫ്രീഡം എന്ന് വെച്ച് കഴിഞ്ഞാൽ നമ്മളൊരു മിസ്റ്റേക്ക് ചെയ്യുമ്പോൾ അല്ലെങ്കിൽ നമ്മളെടുത്തുനിന്ന് ഒരു പേഷ്യൻ്റ് എന്താ പറയുക, സാറിന് ചിലപ്പം ചീത്ത പറയില്ലായിരിക്കും, സാറിനോട് ചിലപ്പം മിസ്റ്റേക്ക് വന്ന് അവർ ആക്സെപ്റ്റ് ചെയ്യുമായിരിക്കും. പക്ഷേ നമുക്ക് ആ ഫ്രീഡം ഇല്ല. നമ്മുടെ അടുത്ത് നിന്ന് സാറിൻ്റെ അടുത്ത് നിന്ന് കിട്ടുന്ന സ്റ്റാൻഡേർഡ്സാണ് നമ്മൾ എക്സ്പെക്ട് ചെയ്യുന്നത്. അപ്പോൾ നമുക്ക് എല്ലാ സ്പെഷ്യാലിറ്റിയും നമുക്ക് കൈവെക്കാൻ ഫ്രീഡം ഉണ്ടോ എന്ന് ചോദിച്ചാൽ അതില്ല. അപ്പോൾ അത് പ്രതാപ് സാർ പറഞ്ഞ രീതിയിൽ തന്നെ ആൾക്കാരുടെ പെർസെപ്ഷൻ മാറിയിട്ടുണ്ട്. അപ്പോൾ അതിൻ്റെ ഫ്രീഡം നമുക്ക് കുറവുണ്ട്. അപ്പോൾ അതിൻ്റെ ചട്ടക്കൂടിലാണ് നമ്മളിപ്പോൾ വർക്ക് ചെയ്തുകൊണ്ടിരിക്കുന്നത് കൂടെ പറയും.
ജസ്റ്റ് 1-2 പോയിന്റാണ്. ബേസിക്കലി ഐ ആം എ ജനറൽ സർജൻ ബേസിക്കലി. ഞാൻ സ്വന്തം വാസ്കുലർ സർജൻ ആയതാണ്. ഇപ്പോൾ എല്ലാവരും എന്നെ അറിയപ്പെടുന്ന വാസ്കുലർ സർജൻ ആയിട്ടാണ്. ഐ എം ബേസിക്കലി ജനറൽ സർജൻ. അപ്പോൾ എന്താണെങ്കിലും ദർ ആർ 2-3 തിങ്സ്. യു ഷുഡ് ബി പാഷനേറ്റ് ഇൻ ദ സ്പെഷ്യാലിറ്റി. ഒരു സാധനം ചെയ്യണമെന്ന് വിചാരിച്ചാൽ അത് ചെയ്തെടുക്കണം എന്നൊരു ഇൻറ്റൻറ്റ് മനസ്സിലുണ്ടെങ്കിൽ യു ക്യാൻ ബിക്കം എ ഗുഡ് ജനറൽ സർജൻ. ഇപ്പോൾ പേഷ്യൻസിനെ പറ്റി പറയുകയാണെങ്കിൽ പ്രീവിയസ്ലി ഇവിടെ കാലിക്കറ്റ് പക്ഷേ ഒരു 20 ജനറൽ സർജൻസ് പ്രൈവറ്റിൽ ഉണ്ടായിക്കാണ്, അത്രയും ഉണ്ടായി കാണില്ല. ഇപ്പോൾ അത്ര 100 ജനറൽ സർജൻസ്. എല്ലാവർക്കും പേഷ്യൻ്റ് ഉണ്ട്, പേഷ്യൻസ് വരും. പണ്ട് കാർഡിയോളജിസ്റ്റ് ഉണ്ടായിട്ടില്ല ഇവിടെ കോഴിക്കോട്. ഇപ്പോൾ എത്ര കാർഡിയോളജിസ്റ്റ്, എത്ര ആൻജിയോളജിസ്റ്റ്, പ്രൊസീജിയേഴ്സ് വിൽ കം. ഇറ്റ്സ് നോട്ട് പ്രൊസീജിയർ ഒരു ദിവസം എല്ലാം തീർന്നു ഒരു കഥ കേട്ടില്ല. നമ്മളിങ്ങനെ ഒരു സൈക്ലോൺ ഉണ്ട്, റോട്ടിലാണ് ഹെർണിയുണ്ടോ വെച്ച് നടക്കുന്നത്, അങ്ങനെ ഒരിക്കലും വരാൻ പോകുന്നില്ല. യു ഷുഡ് ബി പാഷനേറ്റ് അബൌട്ട് വൺ തിങ് ആൻഡ് ഡു ദാറ്റ്. ഈ സബ് സ്പെഷ്യാലിറ്റി എന്നൊരു സംഭവം വളരെ ട്രൂ ആണ്. കോർട്ടിൽ ഓൺലി ആസ്ക് യു വെദർ ആർ യു ട്രെയിൻഡ് ഇൻ ദ പ്രൊസീജിയർ. ഇല്ലാണ്ട് കോർട്ട് ചോദിക്കാവുന്ന മുകളിൽ നിങ്ങൾക്ക് MCH ഉണ്ടോ എന്ന് ചോദിക്കാൻ പോകുന്നില്ല. If you are trained in general surgery and you are eligible to do one procedure, you can do that. പക്ഷെ അതിന് ട്രെയിനിങ് എടുക്കണം, പോയിട്ട് ഡെവലപ്പ് ചെയ്യണം, and you should become good in that. If you are good in that, people will come and follow you, they will come and get operated from you. I'll take some examples. ഇപ്പോൾ ശ്രീജൻ സാർ ഈസോഫാഗസ് ചെയ്യുന്നുണ്ട്, സാറിന് MCH ഇല്ല. ഹുനൈസ് പാരാതൈറോയ്ഡ് ചെയ്തിട്ടുണ്ട് കുറേ. സാറ് സ്പെഷ്യലൈസ് ചെയ്തിട്ട് ബട്ട് ഹി ഡസ് പാരാതൈറോയ്ഡ് നൈസ്ലി ആൻഡ് പേഷ്യൻസ് ആർ കമ്മിങ് ടു ഹിം. ഡോക്ടർ ഇസ്മയിൽ ഹി ഡസ് ലോട്ട് ഓഫ് ബെരിയാട്രിക് സർജറി, ഹി ഈസ് എ ജനറൽ സർജൻ. അപ്പോൾ അങ്ങനെ ഒരിക്കലും അങ്ങനെ ഒരു ഇത് എനിക്ക് തോന്നുന്നില്ല. ഐ സ്റ്റിൽ ബിലീവ് ദാറ്റ് ജനറൽ സർജറിക്ക് നല്ല സ്കോപ്പ് ഉണ്ട്. ബട്ട് യു ഷുഡ് ഡു ഇറ്റ്. അത് ചെയ്യണം തോന്നണം, അത് ചെയ്യും വേണം. ഇല്ലാണ്ട് വെറുതെ ഇങ്ങനെ ഇറങ്ങിപ്പോയിങ്ങാണ്ട് എനിക്ക് പേഷ്യൻ്റ് ഇല്ല പറഞ്ഞാൽ പേഷ്യൻ്റ് വരില്ല. അനദർ എക്സാമ്പിൾ അന്നാമാണ്. ഷീ ഈസ് ഫോക്കസിങ് നൗ ഓൺ ബ്രസ്റ്റ് ആൻഡ് പെരിയനൽ പ്രോബ്ലംസ് ഇൻ പ്രൈവറ്റ് പ്രാക്ടീസ് ആൻഡ് ഷീ ഈസ് ഓൾസോ ഡൂയിങ് വെൽ. അപ്പോൾ അങ്ങനെ ഇഷ്ടംപോലെ എക്സാമ്പിൾസ് ഐ ക്യാൻ കോട്ട്. ഡോക്ടർ ജിമ്മി, ഹി ഈസ് നോട്ട് എ thoracic surgeon, he is doing a lot of thoracoscopic surgery. അപ്പോൾ അങ്ങനെ ഇഷ്ടംപോലെ എക്സാമ്പിൾസ് ഉണ്ട്. അപ്പോൾ ഇഫ് യു വോണ്ട് ടു ഡു സംതിങ് ഇൻ ലൈഫ് യു ക്യാൻ റിയലി അച്ചീവ് ഇറ്റ്. അത് പ്രൈവറ്റിലാണെങ്കിലും പബ്ലിക്കിലാണെങ്കിലും അത് ഇഷ്യൂ ഒന്നുമില്ല. പിന്നെ മണി ഈസ് നോട്ട് എ ഇഷ്യൂ. ഞാൻ എഴുതി വെച്ചാൽ പ്രൈവറ്റ് പ്രാക്ടീസ് വിൽ ഗെറ്റ് ഇനഫ് ഓഫ് മണി ടു ലേൺ ടു ലിവ് ലാവിഷ് ലൈഫ്. ജീവിക്കാനുള്ള പൈസ കിട്ടും. അതുകൊണ്ട് അതൊന്നും ആരും പേടിക്കേണ്ട, അതൊക്കെ തന്നെ വന്നോളൂ. ഇതൊന്നും അതും ആദ്യം എന്ന് പൈസ ചിന്തിച്ച് ഇങ്ങനെ പോകുന്നു വേണ്ട. ഇറ്റ് വിൽ കം, ഇറ്റ് വിൽ ഫോളോ യു ഓട്ടോമാറ്റിക്കലി. അപ്പോൾ പാഷൻ വേണം മെയിൻലി. പിന്നെ ജനറൽ സർജറിയിൽ എന്ത് സർജറി ആണെങ്കിലും, ഇപ്പോൾ യൂറോളജി എടുത്തു, യു ആർ നോട്ട് ഗുഡ് ഇൻ ദ സർജറി, യുവർ ഹാൻഡ്സ് ആർ ബാഡ്, പേഷ്യൻ്റ് വിൽ നോട്ട് കം ടു യു. അത് എവിടെയാണെങ്കിലും ഉണ്ടാവും. അൺലെസ് യു ആർ എ ഗുഡ് സർജൻ, ഗുഡ് സ്കിൽ സെറ്റ്സ്, യു വിൽ ഡെഫിനറ്റ്ലി ബിക്കം സക്സസ്ഫുൾ. ഒരിക്കലും ജനറൽ സർജറി ഒരു സ്പെഷ്യാലിറ്റി എല്ലാം ഇപ്പോഴും ഞാൻ വിശ്വസിക്കുന്നില്ല. ദർ ആർ ലോട്ട് ജനറൽ സർജൻസ് ആർ ഡൂയിങ് വെരി വെൽ. അതുകൊണ്ട് ഇറ്റ്സ് എ ഗുഡ് സ്പെഷ്യാലിറ്റി ടു സ്റ്റിക്ക് ഓൺ ടു, ബട്ട് യു ഷുഡ് ഫോക്കസ് ഇൻ സംതിങ് ആൻഡ് ബിക്കം ബെസ്റ്റ് ഇൻ ദാറ്റ് തിങ്. അതൊരു ബെസ്റ്റ് ആയില്ലെങ്കിൽ പിന്നെ കാര്യമില്ല. യു ബിക്കം എ ജനറലൈസ് സർജൻ ആകുമ്പോൾ യു ഷുഡ് ബിക്കം എ ഗുഡ് ജനറൽ സർജൻ ഫോക്കസിങ് ഓൺ 1 or 2 things ആൻഡ് ബിക്കം ദ ബെസ്റ്റ് ഇൻ ദാറ്റ്. അപ്പോൾ യു വിൽ ഗെറ്റ് ലോട്ട് ഓഫ് പ്രിവിലേജസും കിട്ടും, യു വിൽ ഗെറ്റ് മണി, യു വിൽ ഗെറ്റ് എന്താണ് എല്ലാം നെയിം ഫെയിം ഒക്കെ കിട്ടും. അപ്പോൾ ഐ സ്റ്റിൽ ബിലീവ് ജനറൽ സർജറി നല്ല സ്കോപ്പ് ഉണ്ട്. യു ഷുഡ് നോട്ട് ബി ഡിസഹാർട്ടൻഡ് ദാറ്റ് യുവർ ഇൻ ജനറൽ സർജറി ഇനി എന്താവും ചിന്തിക്കേണ്ട ആവശ്യമില്ല.
അല്ല, ഞാൻ രണ്ടുപേരും വിളിച്ചിട്ടാണ്. അഫ്സൽ ഞാൻ പ്രത്യേകം മെസ്സേജ് അയച്ചാൽ വരാൻ വേണ്ടിയിട്ട്. കുരുട്ടുബുദ്ധിയിലൊന്നാണ്. അഫ്സൽ വൺ ഓഫ് ദ ഫ്ലൈയിങ് ജനറൽ സർജനാണ്. അഫ്സൽ ഐ തിങ്ക് നിർമ്മല പല സ്ഥലത്തും പോകുന്നുണ്ട്, എൻ്റെ വൈഫും പറഞ്ഞു. അപ്പം അഫ്സൽ ഞാൻ ആദ്യം കേൾക്കുന്ന ഗോപി സാർ പറഞ്ഞത് കാഷ്വാലിറ്റിയിൽ പെർഫറേഷൻ അഫ്സൽ ഒറ്റയ്ക്ക് ലാപ്പിൽ ചെയ്തെന്ന് തോന്നുന്നു അല്ലേ? അപ്പോൾ അങ്ങനെയാണ് ഗോപി സാർ പറഞ്ഞു ഞാൻ അഫ്സലിനെ അറിയുന്നത്. അഫ്സൽ ഈസ് പാഷനറ്റ് അബൌട്ട് ജനറൽ സർജറി, ഹീ സർവൈവിംഗ് വെൽ. അപ്പോൾ അഫ്സലിനെ അതിനുവേണ്ടിയാണ് വിളിച്ചത്. ദിനുലാലിനെ വിളിച്ചായിരുന്നു, ദിനുലാൽ വന്നിട്ടില്ല. വാട്ട്സ് യുവർ ഒപ്പീനിയൻ ജനറൽ സർജറി?
ഓഫ് കോഴ്സ് ജനറൽ സർജറി അതിന് എപ്പോഴും സ്കോപ്പ് ഉണ്ട്. എൻ്റെ ഒരേ ഒരു ഓപ്ഷൻ ജനറൽ സർജറി മാത്രമായിരുന്നു. നീറ്റിന് എൻട്രൻസിന് വേറെ ഓപ്ഷനൊന്നും ഞാൻ വെച്ചിട്ടുണ്ടായിരുന്നില്ല. ആൻഡ് ഇറ്റ്സ് എ സർപ്രൈസ് ടു കോൾ മീ ഹിയർ. താങ്ക് യു ഫോർ കോളിങ് മീ. ഞാൻ UG ചെയ്യുമ്പോൾ ഇറ്റ് വാസ് ലൈക്ക് തേർഡ് സെമസ്റ്റർ. അപ്പോഴാണ് ഞാൻ സർജറി എടുക്കണം എന്ന് ആഗ്രഹിച്ചത്. ബിക്കോസ് MBBS ജോയിൻ ചെയ്യുന്നതിന് മുന്നേ എനിക്ക് പീഡിയാട്രീഷ്യൻ ആവണമെന്നായിരുന്നു. പക്ഷേ വൺസ് ഐ സ്റ്റാർട്ടഡ് മൈ ക്ലിനിക്കൽ പോസ്റ്റിംഗ് I decided I'm not going to be a surgeon. And പറയാനുള്ളത് എന്താണെന്ന് വെച്ചാൽ physicians, I see them as magicians. Like they treat the patient, they tell the result. But സർജൻസിനെ സംബന്ധിച്ചിടത്തോളം പേഷ്യൻസിന് ആ റിസൾട്ട് അപ്പം തന്നെ അറിയാൻ പറ്റും. അതാണ് അതിൻ്റെ ഏറ്റവും വലിയൊരു അഡ്വാൻറ്റേജ് ആയിട്ട് എനിക്ക് തോന്നിയിട്ടുള്ളത്. ആൻഡ് ഓഫ് കോഴ്സ് ജനറൽ സർജൻസ് വിൽ എക്സിസ്റ്റ് ആൻഡ് ദേ ക്യാൻ എക്സിസ്റ്റ്. I myself is an example. I haven't even applied for any MCH because I always wanted to be a general surgeon. Thank you.
എൻ്റെ ഇനി അടുത്ത ടോക്കും നിങ്ങളെല്ലാം പറഞ്ഞു തോന്നുന്നു. അത് ജനറൽ സർജൻ ഇങ്ങനെ സർവേ ചെയ്യുന്നുണ്ട്. ഇത് കൺക്ലൂഡ് ചെയ്ത് പറ്റില്ല. ഞാൻ കുറേ സ്ലൈഡ് അതിൻ്റെ ഇടയ്ക്കുണ്ടെങ്കിൽ സ്കിപ്പ് ചെയ്തു. സർ, എല്ലാവരുടെയും ഒക്കെ ഒരു ടിപ്സ് ഫോർ എമർജിങ് സർജൻ സ്റ്റാർട്ടിങ് ഫ്രം ശ്രീ.
I have only one thing to say: dedication, passion, and hard work. These 3 things are required for in any profession. Like that, in general surgery also, one should have that, and one should be sincere to the patient.
എല്ലാവരും പറയുന്നത്
I think it's the same thing that will come from everybody.
As we heard, everybody should have a sound knowledge, basic training, and dedicated, hardworking, and sincerity, and sincere to the patient, and treat the patient as an individual, not as a disease.
Be passionate about your work and focus on whatever you are doing like that. And general surgery is I think, a fantastic specialty where you get to see all sorts of cases like that. So that is, be passionate about whatever you are doing and be sincere.
Yeah, apart from that, all I would say that please be in touch with the changing trend. Accept the changing trend and get used to it, because that is the way of survival. General surgery is a fantastic specialty. Even now, it will continue. It will persist. It will live through ages. I'm sure about that. The only thing is that you probably get involved in a couple of specialty issues and then concentrate on that. Not be a jack of all trades. Don't be trying to be a jack of all trades. So as Sunil was telling that he is interested in vascular surgery, he has not moved away from that. That's a very important aspect. Okay. Be compassionate, and you must have adequate empathy with the patient, and always try to enjoy the good results that you are getting out of the things that you have done. That's all that I have to communicate.
What I would like to say is that you are all going to be the successful surgeons. What I think is that a good quality of a surgeon he is not making any cutting. He is to decide when not to cut, and that case the importance and not when to cut. It is in making the decision when not to cut. And I think this principle has to be followed. And thank you.
Off the days also, I will, like Madhavan sir and Ramlal.
സുല്ല് പറഞ്ഞെടുത്തെന്നാണ് ഞാൻ തുടങ്ങുന്നത്. അതായത് ഒരു ജനറൽ സർജൻ നിങ്ങളൊരു MS കഴിഞ്ഞിട്ട് അല്ലെങ്കിൽ കുറച്ച് ട്രെയിനിങ് കഴിഞ്ഞിട്ട് ഒരു സ്ഥലത്തേക്ക് പോയി ഇരിക്കുമ്പോൾ ദ മോസ്റ്റ് ഇമ്പോർട്ടൻറ്റ് ക്വാളിറ്റി യു ഷുഡ് ഹാവ് ഈസ് യു ബി അവൈലബിൾ. പലരും എൻ്റെ കുട്ടികൾ പലരും ചെയ്യുന്നത് ഞാൻ കണ്ടിട്ടുണ്ട്. 1 മാസം അവിടെ പോയിരുന്നു, എന്നിട്ട് പറയാം എന്താ ഇപ്പോൾ അവിടെ പേഷ്യൻ്റ് ഇല്ല. 3 മാസം വേറൊരിടത്ത് പോയിരുന്നു, അവിടെ നിന്നും പോന്നു, എന്താ ഇപ്പോൾ അവിടെ പേഷ്യൻ്റ് ഇല്ല. ആ ഹോസ്പിറ്റലിൽ എത്ര നാൾ വർക്ക് ചെയ്തു? 6 മാസം വർക്ക് ചെയ്തു. അവിടെ എന്താ കുഴപ്പം? അവിടെ പേഷ്യൻ്റ് ഇല്ല. സോ അവരിങ്ങനെ വാണ്ടർ ചെയ്തുകൊണ്ടിരിക്കുകയാണ്. റോളിംഗ് സ്റ്റോൺസ്. സോ ബി അവൈലബിൾ സംവെയർ. എവിടെയാണോ നിങ്ങൾ പ്രാക്ടീസ് ചെയ്യാൻ ഉദ്ദേശിക്കുന്നത് അവിടെ അവൈലബിൾ ആയിരിക്കുക. ഇപ്പോൾ 4 to 6 ആണ് നിങ്ങൾ കൺസൾട്ടേഷൻ ടൈം എടുക്കുന്നതെങ്കിൽ 1 പേഷ്യൻ്റ് ഉണ്ടാകാം, 2 പേഷ്യൻ്റ് ഉണ്ടാകാം, 1 പേഷ്യൻറ്റും ആഴ്ചകളോളം ഇല്ലെന്ന് വരാം. പക്ഷേ എന്നാലും ആ 4 to 6 യു മസ്റ്റ് ബി അവൈലബിൾ ദെയർ. പിന്നെ ഒരിക്കലും നമ്മൾ ആദ്യമേ നമുക്ക് ആൾക്കാർ കൊണ്ടുവന്നിട്ട് വിപ്പിൾ തരും, അല്ലെങ്കിൽ ഈസോഫാഗക്ടമി തരും, അല്ലെങ്കിൽ APR റിസെക്ഷൻ തരും, അതൊന്നും വിചാരിക്കരുത്. യു ഷോ യുവർ സ്കിൽ ഫ്രം ദ ബിഗിനിങ്. പറഞ്ഞല്ലോ, ഇവിടുത്തെ സെബേഷ്യസ് സിസ്റ്റം മുതൽ അങ്ങേയറ്റം ഇൻഗ്രോയിങ് ടോ വരെ നമ്മളെടുക്കും. അപ്പോൾ അതൊക്കെ എടുത്ത് നിങ്ങൾ പ്രൂവ് ചെയ്യുക, നിങ്ങളെ തന്നെ സ്വയം പ്രൂവ് ചെയ്യുക. ഡെഫിനറ്റ്ലി എ സാറ്റിസ്ഫൈഡ് കസ്റ്റമർ ഈസ് ദ ബെസ്റ്റ് അഡ്വർടൈസ്മെൻറ്റ്. അവർ കൊണ്ടുവരും നിങ്ങൾക്ക് പേഷ്യൻറ്റിന്. അതുപോലെ നിങ്ങൾ ആദ്യം പ്രിപ്പയർ ചെയ്ത് നിങ്ങൾ സെറ്റാക്കി വെച്ചിരിക്കുന്ന പേഷ്യൻ്റ് ചിലപ്പോൾ പോയെന്നിരിക്കും. നിങ്ങൾ ജസ്റ്റ് ബിക്കോസ് യു ആർ എ ജൂനിയർ, നിങ്ങൾ സെറ്റാക്കി വെച്ചിരിക്കുന്ന പേഷ്യൻ്റ് നിങ്ങളുടെ അടുത്തുനിന്ന് പോകും. അപ്പോൾ അവിടെ ഒന്നും വിഷമിക്കരുത്. ചില കേസൊക്കെ നമുക്ക് ചെയ്യാൻ പറ്റാതെ വരും, അവിടെയും വിഷമിക്കരുത്. പക്ഷെ കണ്ടിന്യൂസ് ആയിട്ട് നമ്മൾ ആ എഫർട്ട് കൊടുത്തുകൊണ്ടിരിക്കുക. ഒരു സ്ഥലത്തെ അവൈലബിലിറ്റിയും ആ ഒരു സ്ഥലത്ത് നിങ്ങൾക്ക് പിടിച്ചു നിൽക്കാനുള്ള ശേഷിയും തന്നെയായിരിക്കും ഒരു ജനറൽ സർജനെ എസ്റ്റാബ്ലിഷ് ചെയ്യാൻ പോകുന്നത്. സോ വിഷിംഗ് യു ഓൾ ദി ബെസ്റ്റ്.
Madhavan sir.
മാനവസേവ മാധവസേവ എന്ന് പറയാറുണ്ട്. അതാണ് മോസ്റ്റ് ഇമ്പോർട്ടൻറ്റ് പേഴ്സൺ in your field is the patient. I always used to say the theatre is a temple for the surgeon and the patient is the God. By serving the patient, you serve the God also. എൻ്റെ അച്ഛൻ്റെ ജ്യേഷ്ഠനുണ്ട്, മദ്രാസ് മെഡിക്കൽ കോളേജിൽ പ്രൊഫസർ റിട്ടയർഡ്. ഞാൻ പാസ്സായപ്പോൾ എന്നോട് പറഞ്ഞ യു ലുക്ക് ആഫ്റ്റർ ദ പേഷ്യൻസ് വെൽ, ദേ വിൽ ലുക്ക് ആഫ്റ്റർ യു വെൽ. Money should not be your criteria for practice. Money will come.
Nirmal sir.
You've all been privileged to hear the talk from very senior members of the profession. I think you should be satisfied with what you have already heard from them. I don't have much to add except that whatever you do, do it sincerely. Even if it's a small injury on the face to a beautiful lady, the way you suture will be gratifying for you and to the patient. So whatever you do, do it sincerely and nicely. And the basic sciences like anatomy, pathology, all these one should know before you start wielding your knife. Thank you.
Shailesh sir. പ്രധാനമൻ സാർ വിപ്പിള് ലാപ്പല്ല സ്റ്റാൻഡേർഡ് ഓഫ് കെയർ എന്ന് പറഞ്ഞു. പക്ഷേ ശൈലേഷ് സാർ ചിലപ്പോൾ മാറ്റി പറയും. സാർ യു റൈറ്റ്.
ഇല്ല, എനിക്ക് തിങ് ഈസ് future is actually organ specific surgery. You like it or not, you discuss it many times, but future is like that, organ specific. ഇപ്പോൾ ഈ പറഞ്ഞ ജനറൽ സർജറി പോലെ തന്നെ ഗ്യാസ്ട്രോ സർജറി, ഓങ്കോ സർജറി, all will become obsolete. It's organ specific surgeon, thyroid surgeon, breast surgeon, esophagus surgeon, liver surgeon. This is going to be like that. So better accept the reality and train it. Train single organ specific surgery. That's the future വരാം. Even with general surgery, degree doesn't matter. As Sunil said, degree doesn't matter. You don't need any MCA degree, but you train in one specialty degree and concentrate on it and become better on it. But if you have a MCH degree, it will help you in establishing the practice. That's it. But after seeing to progress in practice, you need a skill and organ-specific training. Second thing, Pradhavan പറഞ്ഞ same thing. First, usually പറയുന്ന ഒരു dictate, you have to study open surgery first to do laparoscopy. But only in very few cases like hernia it is required, where anatomy is completely different. Because open surgery is much more easier than laparoscopy. You do any surgery, any gastrectomy, colectomy, anything. If you, moment you open it, you put your hand inside, then it becomes very easy. So even if you are doing a laparoscopy regularly, if in a difficult case, you can always convert. No need for a structured training. It's almost steps, everything almost very similar. ഓപ്പൺ സർജറി ചെയ്യുന്നു, ആദ്യം ലാപ്രോസ്കോപ്പി പഠിച്ച ആൾ ഒരു കൊളക്ടമി ചെയ്യുന്നു, പറ്റുന്നില്ലെങ്കിൽ ഓപ്പൺ ചെയ്യാൻ ഈസിയറാണത്. ഓപ്പൺ വേറെ പഠിക്കേണ്ട ആവശ്യമില്ല. സെയിം തിങ് ആണ്. ജസ്റ്റ് ലാപ്രോട്ടമി ചെയ്യാൻ ആ ഇനീഷ്യൽ നമ്മുടെ ആ സ്കിന്നും മസിലും കട്ടിയാലും മാത്രം പഠിച്ചാൽ മതി. എക്സെപ്റ്റ് ഹെർണിയ ഓപ്പൺ സർജറി ലാപ്രോസ്കോപ്പി എൻറ്റയർലി ഡിഫറൻറ്റ്.
ബഷീർ സർ, ഒരു ചെറിയ അനൗൺസ്മെൻ്റ് ഉണ്ട്. I will thank all the panelists for making the discussion lively. Thank you all. Medtronicന്റെ താങ്ക്സ് പറയേണ്ട ആവശ്യമില്ല. പ്രോബ്ലി തേർഡ് ഓർ ഫോർത്ത് മീറ്റിംഗ് ദേ ആർ ഡൂയിങ് ഫോർ കാലിക്കറ്റ് സർജറി ക്ലബ്. അവരുടെ പ്രോഡക്റ്റ് ഞാൻ തന്നെ പറഞ്ഞാൽ മതിയോ? അവർക്ക് വെരിസെറ്റ്, ഇപ്പോൾ വെരിസെറ്റ് നിങ്ങൾ ആപ്പ് ജെല്ല് പോലെ വെരിസെറ്റ് ഒരു മീറ്റിങ്ങിൽ ഫേമസ് ആയതുകൊണ്ടാണ് അവർ പിന്നെ മീറ്റിംഗ് ചെയ്യുന്നത്. പിന്നെ അവരുടെ സിഗ്നിയ സിസ്റ്റം ആൻഡ് ദേ വിൽ ബി റണ്ണിങ് ദ ലൈവ് of that video and energy device pinne parayandallo Lageshwar aanu ellarneയും. So thank you Medtronic division for again sponsoring us. I think they are sponsoring 2 more meeting here and there for everything. Thank you. Thank you panelists. ഒരു ചെറിയ announcement.
Rather than an announcement, we had announced a general body meeting for change of this office bearers. We're not having a general body meeting. Instead, we will now propose the next president and secretary. Before that, I will thank every surgical club members for the happy experience in the last 2 years. We didn't feel that 2 years passed. Usually, we rotate every year, but we took 2 years. Maybe we were power-hungry people, I don't know. And now it is the best time to change after having finished every audit. You had the audit report in the last meeting. Also, we will have one more meeting already announced. We will have next 27th. The installation will be in the next meeting. And as the president, Dr. Ramesh from KMCT will be the president, and Dr. Abba from Calicut Medical College will be the secretary. I congratulate both of you for the prospective taking out of the office and
ഡിന്നറിനിടയ്ക്ക് കാണിച്ചാൽ മതിയോ? ടൈമ് പ്രോഡക്റ്റെല്ലാം പോവും. വെരിസെറ്റ്, ലാഗേശ്വർ, സിഗ്നിയ. You'll show the. Thank you for coming.
The meeting is adjourned.
Commentary ഞാൻ കൊടുക്കും. വീഡിയോ ഇത് കണക്ട് ചെയ്തിട്ടില്ല.
Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Experience the evolution of freedom of movement. From the trusted name in cordless ultrasonic dissection devices. Introducing the next generation Sonicision 7 curved jaw cordless ultrasonic dissection system with the cordless freedom you expect and the advancements you've asked for. The cordless design reduces the challenge of managing cords in the sterile field and allows for more natural movement in the OR, along with easier instrument exchanges, contributing to a safer OR. Available in 4 shaft links to help meet your specific need, the Sonicision 7 curved jaw cordless ultrasonic dissection system enables effective vessel coagulation and dissection in open and minimally invasive surgical procedures. And now the Sonicision 7 curved jaw system is indicated to coagulate and dissect vasculature up to and including 7 millimeters in diameter using minimum mode and up to and including 5 millimeters in maximum mode. The tapered design of the curved jaws enables precise access to tissue planes in confined spaces. The intuitive dual-mode energy button is designed to improve focus on the surgical field and procedure. The Sonicision 7 curved jaw system has an improved reusable generator that is now autoclavable and works for 150 procedures before you need to replace it. The improved battery can be used in twice as many procedures. The redesigned charger features a user interface that provides easy-to-interpret battery charge status and battery end-of-life indications, enabling efficient battery management. The non-sterile nature of the battery also removes the need for sterilization and streamlines preparation for reuse and provides an 88% increase in battery capacity. The Sonicision 7 curved jaw cordless ultrasonic dissection system. Feel the freedom.